second time. It's my pleasure to introduce you to Brian Stahulek, who's our Chief Nursing Officer and Senior Vice President.
Great.
Welcome, Brian.
And welcome to everybody to the JBI Lurie Children's gLocal Solutions Group. I'm excited to have us a part of JBI, the JBI Collaborative. I think it does bring a lot of information and education to our teams and helps us to continue to be very focused on how we're going to practice in a very evidence-based practice way. And I think that's a really important thing. I want to thank all of the speakers who are presenting today. Congratulations, you guys, for speaking. I think we've done a lot of great work here, and it's really exciting to be in a place where we can share that information beyond the walls of Lurie Children's. And it's exciting to have everybody who's online joining us and participating as well. Thank you to the JBI Precise core staff for helping us organize this. This is a really great opportunity for us as an organization to really show the work that we've done. Today's highlights, I think, the importance of evidence-based practice that we have and the contributions of nursing and graduate education that it has on our organization. So we have, on an every year basis, we have hundreds of students who are coming through the organization doing projects at the organization. And I think the ways that we should be thinking about how we tie those projects to organizational goals is a really important component. I think it helps drive opportunities and return on our team's resources and staff, that investment of our people to the organization. It also, I think, helps lead to a more meaningful educational experience for the students who are going through the process, right? As you go through and hear the talks today, some of those projects that were really tied to organizational strategies were just very meaningful because the students not only are participating and contributing in a very high way, but they see the impact that has on the organization. So I want to thank people for thinking about that because that takes work to do that. It takes the organization's commitment to thinking about what our strategies and goals are going to be and what is our process for intaking those students into our organization as graduate students to really assigning them the things that are really important for us as an organization. We all, as healthcare professionals, have a million things to do. We all have all goals that are probably beyond the scope of what we can all manage in a single year. The way that we can get those things accomplished and have meaningful impact is to engage with our graduate nursing students to say, here are the projects that are going to help us. So it does a lot of things. I think, from the perspective of the student, it also from the mentor of the person who is helping lead that student really helps engage them in a new way of how we delegate, how we coach, how we mentor. And as nursing leaders, our role is to really be those educators and really mentoring the next generation of our leadership team. So there's a lot of things that are accomplished with that. So I hope through the day, the speakers and presentations help us think a little bit more about how we can do that even more successfully. And I thank and welcome everybody to Lurie Children's. So
Thanks.
Great.
Thank you. So thank you to Brian for that lovely welcome. And next, it is my pleasure to introduce Dr. Audrey Rosenblatt. She's a certified registered nurse anesthetist and director of advanced practice anesthesia services at Lurie Children's. And along with Dr. Lauren Source, she co-directs the JBI Lurie Children's Pediatric Research Implementation and Synthesis Center. That's a mouthful, right? She holds a PhD in nursing science with a specialization in qualitative research methods, medical decision-making, and lived experiences of clinicians from medical training. So welcome, Audrey.
Thank you, Sue. To share really quickly the agenda, which you guys have in front of you, but the people online don't have. So we're going to get started. I'll do an introduction to JBI for people who aren't familiar with JBI, kind of give an overview of what that is. Then we're going to have some speakers talk about graduate nursing education and share a little bit about Lurie as an organization. We're going to have Emily Needs talk about the nursing project tracker and go through some of the ways that we organizationally incorporate graduate nursing education and awareness of what's going on and administrative oversight. We'll have Eileen Romano present about her work with the graduate students because she was mentor for many of the student projects. Yep. And then we're going to have 4 of our graduate students present their work and the projects they did and talk about the organizational impact that they had. And then we will wrap it up with hearing from our mentors with a little mentor panel. So I'm really excited about today. I hope everybody has something that they can take away, take back to their administrative leadership, clinical practice. All right. So in this brief presentation, we would like to introduce JBI, its model of evidence-based healthcare, and the origins and purpose of the JBI gLocal Solution Room. At its core, JBI is concerned with improving health outcomes in communities globally by promoting and supporting the use of best available evidence to inform decisions made at the point of care. This work begins and ends with the needs of those working in and using healthcare services. JBI seeks to respond to their questions and provide high quality, reliable information that is pragmatic and useful where it counts. So who are we? JBI is an international research organization that develops and delivers unique evidence-based information, software, education, and training designed to improve healthcare practice and health outcomes. To achieve this, JBI works with universities and hospitals from across the globe through the JBI Collaborative. So we are one of the JBI Collaborative centers throughout the world, and we meet once a year. Last year we met in Prague, this year we're meeting in Kochi. All of the centers come together and share what's happening at their organizational levels, the projects they're doing, challenges they're facing, and things that they're moving forward in initiatives. In doing this, JBI ensures that research evidence it seeks to synthesize, transfer, and implement is culturally inclusive and relevant across the diversity of healthcare internationally. For those of you who are perhaps unfamiliar with JBI, their vision is to provide better evidence to achieve better outcomes and a brighter future. Our mission is to promote and support the use of evidence at the point of care. And of course, JBI can't do that alone. They are located in Adelaide. And so to have international reach, they work through the JBI Collaborative. And as a literature synthesis and research organization, they have 2 separate main arms. So one of those is the literature synthesis, which is methodologies for systematic reviews, scoping reviews, umbrellas. How do we synthesize the research that's available? And then how do we move that research into practice so that patients benefit from the research that's happening, the synthesis of that information, so that we can use it to change healthcare. It's hard without a presenter view. Oh boy. So in order to provide those who work in and use healthcare systems globally with world-class information and resources, JBI considers international evidence related to the feasibility, appropriateness, meaningfulness, and effectiveness of healthcare interventions. So that's evidence generation. It includes these different types of evidence in formal assessment called a systematic review. So that's evidence synthesis. It globally disseminates the information in appropriate, relevant formats to inform health systems, health professionals, and consumers. So that's evidence transfer. And it has designed programs to enable the effective implementation of evidence and evaluation of its impact on healthcare practice. So that's evidence implementation. And this unique approach is encompassed in the JBI model of evidence, which I think Eileen is going to touch on in a little bit too, so I won't go too far into depth here to steal your talking points. The inner circle represents the pebble of knowledge, while the inner wedges provide JBI's conceptualization of the steps. The outer wedges operationalize the component parts, and the arrows show that there's bidirectional flow between all of those things. So despite evidence-based healthcare, organizations like JBI have been in existence for more than 30 years. And we know that there is a research to practice gap that still exists across all fields of healthcare. The common quoted estimate is 17 years from research to bedside. That lag in uptake is due to numerous gaps in the movement of research from one stage to another, including ineffective dissemination, which JBI seeks to address. And this is where JBI's evidence implementation framework is firmly situated. So evidence-based clinical audit and feedback is an evaluable approach to implementing evidence-based practice. Recognizing and understanding the role of professional culture, organizational support, and leadership in this process is pivotal to its successful utilization. And I think it's really interesting, that professional culture piece and organizational support, because that's what we're talking about today, is what does organizational support look like? And then the professional culture, because every institution and every country is unique in terms of what the professional culture is in that particular space. So even within the same city, you have very different professional cultures as you move from one institution to the next. And so what might work in one facility may not work exactly the same way in another facility. So addressing those gaps and working with the people who are providing the care, I think is so important. And this is one of the things that JBI seeks to address. JBI Evidence Implementation Project is a clinically oriented and team-based initiative towards implementing the best available evidence into an organizational system and processes for everyday care. And the evidence implementation projects are quality improvement initiatives using a very similar approach to the Plan, Do, Study, Act cycle, which emphasizes clinical leadership. The JBI implementation approach is grounded in audit, feedback, re-audit process, and it is a structured approach to the identification and management of barriers to change. And one of the things that I've seen when I've been looking at quality projects or doctoral projects that students have done is that even if they have not formally implemented the JBI model in their project, I often see these steps automatically embedded in the work that they're doing, because this is a framework that makes sense for moving things into practice, because part of the embedding of that professional culture change is the sustainability phase. And that is one area that graduate projects often struggle with, because they're done with school. And so that's why that organizational support is so critical, because in order to sustain those projects, there has to be organizational buy-in to continue to implement the work that's been done. The widespread impact of the work of JBI worldwide is attributable to local and global partnerships that ensure that activities are context-driven by individuals and groups that understand their specific healthcare environments. So that is using this model in our day-to-day practice with the people that we work with our specific patient population, to make it meaningful for like boots on the ground kind of work. Through its international evidence network, JBI is well positioned to be a leader in producing, disseminating, and providing a framework for the use of best available evidence to inform clinical decision-making and improve health outcomes globally. So the JBI Collaborative is the engine that drives JBI's worldwide effort to promote and support the best available evidence to inform decisions. So there's more than 90 centers of excellence and affiliated groups in all the regions. We're the little red dot right here. And one of the things that is really lovely about the collaborative is that international reach. And so, for example, for me, when I went to the collaborative last year, I was sitting at a table with people from all over the world and hearing the things that they're implementing in their various institutions and the challenges and barriers that they face, which are similar and different from the things that we face every day in our clinical practice, depending on where they're working. The JBIC is the largest global collaborative to integrate evidence-based healthcare within a theory-informed model, and it brings together academic entities with hospitals and health systems. Collaborating entities are self-governing and are initiated and coordinated through JBI, and we are driven by a united desire to contribute to improvements in the quality and outcomes of healthcare globally through the delivery of high-quality programs of evidence synthesis, transfer, and implementation. The functions of the JBIC are directed towards the knowledge needs of local clinicians and consumers, with each collaborating entity leading evidence-based initiatives in their region, country, state, or specialty. And I love this picture, the think global, think local, or think local, right? Which is what we're here for today. So I'm going to give a little bit of background about the origins of the JBI gLocal Solution Room. So what is glocalization? Glocalization was popularized by the work of sociologist Roland Robertson, who traced its roots to a Japanese business term, which I can't pronounce. Docha kucha. Yeah, I told you, I can't pronounce it, which emphasizes a global outlook adapted to local conditions. So globalization stresses the idea of contemporary globalization influencing the local level of society and localization of globality. So what does globalization have to do with evidence-based healthcare? The JBI model of evidence-based healthcare recognizes first and foremost the critical relationships between research and practice. The yellow wedge at the top of the model speaks to the global and locality of evidence-based healthcare. And in simple terms, evidence-based healthcare begins and ends with the needs of healthcare professionals, that's all of you, health services, and health service users. Researchers and synthesists are, if researchers and synthesists are not engaged in practice and are not responding to your knowledge needs, then we're not going to achieve sustainable improvements or impact where it matters most. And so that's why events like the gLocal Solution Room are important. So the idea is, well, are we answering the right questions? Are we answering questions that matter as they relate to not only the effectiveness of interventions, but feasibility, appropriateness, and meaningfulness of the interventions, and how those are vital to the success of implementation efforts? So working in collaboration with you is to determine what those questions are, and then supporting you to answer the questions is the only way that we can achieve our mission and vision. All right, so thinking about the application of evidence context is key. JBI is cognizant that our responsibility is to not only provide health professionals with the best evidence, but then to support you in its use. And again, that's not possible without connecting in person, without acknowledging and accepting different cultures and clinical environments present different challenges. And we hope that this event and the series of events that are happening around the world this week will contribute to overcoming some of those barriers to help us generate new knowledge, understand the challenges that we face at the various centers throughout the world, and provide some opportunities to come up with solutions and partnerships together. So the idea of the solution room came from a powerful conference session concept designed to engage and connect attendees, but also from a peer-supported advice on pressing issues. So while the JBI event doesn't strictly follow the format of the original idea, the concept being solution-focused and pragmatic was really attractive to JBI. So pairing that with the real-life challenges related to implementation, which I think the students will definitely touch on later in their individual projects, is an obvious choice and an opportunity for JBI and the JBI Collaborative to engage and talk about the way that evidence-based practice is implemented at the local level with global applicability. So what we're doing here can apply globally because other people can learn from the things that we're doing, and we can learn from what they're doing in other places. So I'm so happy that everyone is here today. Thank you all for coming. Thank you to our amazing speakers. And I also want to say a huge thank you to Rochelle, who has been keeping me safe and reviewing things. Otherwise, both Eileen and Emily would be speaking simultaneously because correct. I sent it to her like 3 times. She's like, they're still both speaking from 9 to 9:30. I will fix it again. So thank you, Rochelle. And she is also the reason you have food, because that would not have occurred to me. So, thank you, everyone. I'm really excited about today.
Thank you.
All right, well, thank you, Audrey, for that lovely introduction to JBI. Nobody does it better. Excuse me. And next, I'm here to talk to us about an overview of graduate nursing education are Melissa Hurley and Casey Benedetto. And Melissa earned her BSN from Northern Illinois University. And has worked as a bedside nurse clinically in the neonatal intensive care unit for 15 years at Evanston Hospital. We're like sisters. Her strong interest in precepting, mentoring, and education led her to obtain her master's degree in nursing education from Benedictine University. She's worked as a clinical educator in inpatient, ambulatory, and academic settings. She currently works at Lurie Children's Hospital in clinical and nursing excellence as a nursing professional development specialist and is the program director for the RN Fellowship Program, Experienced Orientation, and Student Nurse Scholars. In addition, she's the hospital coordinator for all graduate students that come through Lurie Children's. Melissa recently completed the JBI Comprehensive Systematic Review Training Program and is looking to incorporate evidence-based practice methodologies into the RN Fellowship Program. And Casey earned her BSN from Viterbo.
It's named after a city in Italy.
Oh, Viterbo. At University in La Crosse, Wisconsin in 2002, and an MSN in nursing education from the University of Iowa in 2010. She began her career as a staff nurse on a medical surgical cardiac unit in Children's Memorial Hospital in Chicago. And Casey has worked in nursing professional development roles for the past 20 years. Currently serves as the Lurie Children's Program Director for the RN Residency Program. She's also served as adjunct faculty at Elmhurst University in Elmhurst, Illinois, supervising master's level nursing education students completing their evidence-based practice projects. Casey completed the ANPD Evidence-Based Practice Academy in 2024 and the JBI Comprehensive Systematic Review course in 2025. Casey's expertise is in new graduate nurse role transition, precepting, mentoring, and nurse professional development. I'm sure there's more, that's why I turned the page. Anyway, help me welcome Casey and Melissa.
Thank you.
All right. Hi, everyone. Good morning. Very excited to be here with you guys today. Before we jump into our presentation, we just wanted to give an overview of our organization. So we are Ann and Robert H. Lurie Children's Hospital of Chicago, which is a mouthful to say. So moving forward, you will hear us refer to it as Lurie Children's Hospital or Lurie Children's. We are located in, we are a freestanding children's hospital located in downtown Chicago, Illinois, in the United States of America. We have 365 patient beds, over 2,200 nurses, and over 400 APPs or advanced practice providers. We recently celebrated our 6th ANCC magnet designation, which we are very excited about, and we are on our way to the 7th. We are home to JBI Lurie Children's Pediatric Research, Implementation, and Synthesis Center. So that's a little bit about us and our organization. And thank you, Sue, for the wonderful introductions and to put face with a name. I am Melissa Hurley, Program Director for the RN Fellowship Program and the Graduate Student Coordinator, which is what we're really going to be talking about today. So I'm going to talk about my role as the Student Coordinator in how we process and onboard students throughout the organization. And then my co-presenter today is Casey Benedetto, and I'll let you introduce yourself.
Sure. So I'm Casey Benedetto. As to let you know in the introduction, my current role is the Program Director for our Nurse Residency Program. In that program, we do teach evidence-based practice to our newly graduated nurses. In addition, I've had the pleasure as serving as both a preceptor and an adjunct faculty member through our Elmhurst University program. So Melissa's going to talk about a lot of our structures that are in place to onboard graduate students and how their projects get done. I'm going to give a little bit of a practical example from my experience as an adjunct. So turn it back over to Melissa to get started.
All right, next slide. Okay, so throughout our session today, we're really going to be talking about our graduate nursing program and our student nursing population. So I want to give an overview of the numbers so you get an idea of how many students really come through our organizations in a year. We currently have 60 affiliation agreements or contracts with both local and national schools. So that's a lot of schools we have contracts with. And as you can see, we also have a lot of students that come through. In our graduate program, we have 7 different program tracks. And so those program tracks are delineated by our nurse practitioner program track, our SRNA program track, our student registered nurse anesthetist that work with our CRNA colleagues. And then we have nursing education, nursing leadership, nursing informatics, our DNP students, and our MHA preceptorship students. So a lot of different tracks. That's why we have so many schools, 60 different schools, because we do have 7 different tracks or points of entry into the organization. We see for our graduate program, we see about 160 students that come through the organization in a year. And I know that we're really talking about the graduate program, but I'm providing some other numbers so you get an idea of how many other students come through our organization as well. So our undergraduate nursing program, they see about 900 students that come through our organization. I think they have contracts with about 30 or 40 different schools. So these are all of our BSN programs coming for their clinicals. So 900 students a year is a lot. And we have about 75 non-nursing students that come through the organization in a year. And that really consists of our respiratory therapy students, our rehab services, such as PT, OT, speech, OR surgical techs. There's some other students that come that are not nursing as well. I think dentistry. So we do have non-nursing students that filter throughout the organization as well. And from 2023 to date, we have had 72 projects that have been developed and implemented by students throughout the organization. And you will be hearing from some of our students later about their wonderful projects that they developed and implemented. So we'll give you a highlight of some really great projects. So I talked about the 7 different tracks for our graduate program. So there's different points of entry depending on what track you fall in. So the process for onboarding the graduate students for the nurse practitioner program track, we have an annual application process that's actually open right now. So if anyone needs anything for 2026, you can apply for a clinical spot for a nurse practitioner. And then I work with very closely with key leadership teams of every single division for our APP colleagues. So they identify how many students that they can take, and that ultimately lets me know how many students I can accept based on the application process. And as the last slide showed, about 160 students that we can take in a year. So that number really depends on preceptor availability throughout the organization. And we generally have over 200 people that apply, so we can't take all the students that do apply. But I work really closely with the leadership team to determine how many students, and then the students are paired with their preceptors based on their program track, meaning are they an FNP, a PNP, an NNP, you know, what program track are they at as a nurse practitioner, where's their area of interest, where do they want to be clinically. And in the application process, they have to provide their resume and a personal statement. So we look at all of those to identify the students that are going to be coming through the organization, then ultimately pair them with a preceptor that matches their area of interest. And then we have our SRNA program track. So placements are made about a year in advance with our partner schools. So we have 3 schools that we partner with for SRNA students. We get 4 students every other month. And so I work closely with those 3 programs to onboard the SRNA students, and all CRNAs are expected to precept their students. So that is part of their role, that they precept their students in that program. And then we have nursing education, nursing leadership, nursing informatics, our DNP students, and our MHA preceptorship. So this track is all kind of lumped together. There is no application process for this, but I do ask that the student contact me for a preceptor pairing a minimum of 6 months in advance. So either the school or the student, because a lot of times they're internal employees, they'll contact me and say, I'm doing a DNP project, or I'm in the nursing education program, whatever it may be, I'm looking for a preceptor. And then I have a one-on-one conversation. Tell me about your program. What are your program goals? Your program requirements, what are your personal goals? Where's your area of interest? Do you have a project identified? And if you do have a project identified, do you have a preceptor identified? And just kind of really getting an idea of what it is that they want to accomplish, so I can best match them up with a preceptor that's going to help them achieve their goals, and that preceptor that has the area of expertise for that project that they want to develop and implement. So after we identify the students through those various methods, the next step is to really compliance with both the school and the students. So the first thing that I have to do is make sure that we have an affiliation agreement or a contract in place with the schools. Nothing can happen until we make sure this contract is in place. So we can't move forward until that happens. So the contracts could take anywhere from 3 to 6 months to get those contracts put into place. Our legal team is very busy, so I have a whole queue of contracts that I'm requesting. And it's not just me, so it could take a long time for that contract to go through. So that's why we have the application that's a year in advance, or for the other program tracks, at least a 6-month notification. So if I do have to get a contract, if we don't have one and I have to go through that process, that allows us enough time to get that contract signed and completed before the student can start. Because as I said, nothing can happen until that contract is signed, so I don't want to delay any of the students. So that's the first step that takes place. And then all the students need to complete compliance requirements through My Clinical Exchange. My Clinical Exchange is a third-party online program that I have access to, and the school has access to, and the students have access to. This is where we do all of our regulatory compliance through My Clinical Exchange. So the student and the school will upload through My Clinical Exchange proof of their immunization status, proof of a BLS card. They sign their waivers to be here at the organization, and they review any pertinent hospital policies through this. In addition to the affiliation agreement needing to be complete before students can start any hours, this step also has to be complete. I need to see proof of immunizations, and the waivers have to be signed before students can step foot within our organization. So while we're kind of taking care of all that paperwork, in tandem, I am working on hospital access for the students as well. So every student will get a student hospital electronic medical record or EMR accounts. They will get a student ID badge. And then I just help them, students who aren't familiar with our organization, help them with parking, wayfinding. Have you contacted your preceptor? Do you have their contact information? Have they responded? Do you have your schedules? And just really being that point person for the schools and the students in case there's any questions or concerns that I can help them with. A large majority, and I would say about 60% of our graduate program students they have a dual role as both a Lurie employee and a graduate student. And when you have that dual role, sometimes it's hard to separate yourself as a student when you're an employee in your home institution. But this really presents some barriers that I'm going to talk about and some facilitators that I'm going to talk about by having a lot of students having a lot of employees that also serve in the student role. So I mentioned all the processes that have to be put into place, such as the contract and all the compliance. And so if a student who's also an employee doesn't follow those steps, that really puts the organization at risk. So when the employee is here as a student, they are here in a student capacity only. They are covered under their school's insurance, their school's policies. They are not covered under Lurie's insurance, Lurie's policies, or anything as an employee. You are here in a student capacity only. So if these steps are bypassed to be a student here, and we don't have a contract, we don't have you set up with the correct compliance, then that puts the organization at risk from that aspect. Secondly, if students bypass these processes, then I'm not setting them up with a student EMR account or student ID badge. If you're using your employee account to do student activities, that triggers a lot of HIPAA violations. So setting them up with a student Epic account is a key thing so that you can continue to do your student work at the organization and not use your employee account and get flagged for any HIPAA violations. Another barrier that I commonly see is that students will seek preceptors on their own without going through the processes that are put in place, meaning nurse practitioner track, we have an application. So they didn't fill out an application, they work, in the PICU and they go see a PICU nurse practitioner, like, hey, will you be my preceptor? I really need one. They're like, yeah, I'll be your preceptor. And then they kind of have an internal conversation. And then they're here as a student, but then I don't know that they're here as a student because there was an internal conversation. They didn't fill out an application. So then I don't know if there's a contract. We don't have them set up as a student. So if they seek preceptors on their own, that causes some barriers as well. In addition to it happens commonly because you do work at the organization, so you do have partnerships and you know a lot of colleagues, but we also get external people who send LinkedIn messages or cold calling or cold emailing, or hey, you are at my university's alumni board and your name came up, so I'm reaching out to you to be a preceptor. And then if those preceptors say, oh yeah, that's so awesome, I went to Northern Illinois too. I would love to be your preceptor. That's amazing. Yes, let's do it. And then if the preceptor doesn't let me know about those students, again, we bypass all of these processes that are put in place, and really having that affiliation agreement that has the guardrails to protect us as an organization. However, facilitator to having dual roles as employees and students is that our students who are employees, they really know the organization, right? They know our mission, they know our strategic goals, they know the department that they work in and what those department goals are. They can truly really identify a project that meets the needs of that department to help move forward those department goals. So we really love having employees who are students to help us reach some of those goals because they are on those units, they're working on those units, they know the problems, they've been able to identify them and can put the solutions into place. And another facilitator is that they will remain at the institution, hopefully, post-graduation, that they can then sustain that project. So a lot of times if we have students who are external, they come in, they implement, they develop a project, they might implement it, and they're like, okay, see ya, I got my time here is done, and then the project just kind of falls through because there's no one here to see it through and to help sustain it. So as employees who really stay here at the organization, then they can put these wonderful projects into place, but then also help sustain it by still being an employee here. So I think that is it for me. And now I'm going to turn it over to Casey.
Thank you, Melissa. All right, so as Melissa gave us a really wonderful overview of all those structures and processes that are in place for our graduate nursing students, I'm going to talk a little bit about kind of a case study, if you will, or example from one of our programs here at Lurie Children's. So we are so fortunate that we have partnered with Elmhurst University, which is a liberal arts university in the Chicago suburbs, to offer an on-site program to our employees here at Lurie Children's. So I've been fortunate enough to be part of the inception of this program. I've been a preceptor for many students. And then in the 2023-2024 academic year, I was able to serve as an adjunct faculty member. So they have 3 MSN concentrations that the students can choose from when they're here. So nursing administration, nursing education, or clinical nurse leader. So in my role, I mentored projects for the nursing education and for a couple of the CNL students. And then what these programs are able to do is really prepare our employee students for entry-level roles that are needed in our organization, such as, our nursing managers, our nurse educators, or nursing professional development specialists, or a nursing clinical quality coordinator. So how this works is a little different than what Melissa described because we do have this on-site program. So Melissa is the lead on this one as well if she didn't have enough to do already. But the list of employee preceptors is maintained by the university, and then that's shared with Melissa, who's our graduate student placement coordinator. So the nice part about this is the students that go through this program are able to have a preceptor selected for them. They don't have to go out and find a preceptor or do any of that, maybe somewhat not the way we want them to do it, but cold calling or reaching out through LinkedIn or email. They are able to be paired with a preceptor who is a Lurie Children's employee that meets criteria to precept in the program. Elmhurst University then reaches out directly to the employee preceptors and makes that pairing. So that is also a very helpful element. Another benefit to our employees is all the classes are held on site. So that is really wonderful that employees can, be here. They don't have to travel to the suburbs. For some of them, that may be more convenient, but nice to have the classes here on site. And also all of the precepting and then their evidence-based practice projects are completed here on site as well. Currently in the program, we have 36 students, which is wonderful. And I know that we're always looking for more preceptors so that we can accept more students. I see Melissa nodding. Call her. Yeah. All right, so how do we support employee students in this program in completing their evidence-based practice projects? So what I found as both a preceptor and an adjunct faculty member was that these students often needed the most support with that kind of capstone end of program evidence-based practice project. So many of them came into their graduate education with different levels of preparation and evidence-based practice and research. Of course, they go through an evidence-based practice course within their program. It's typically taken before the big project is launched. But at the graduate level, we have nurses that are going back, 1 to 2 years into practice, anywhere to, I went back after 8 years of practice. And I certainly didn't have evidence-based practice in my undergraduate education. So a lot of this, may be new to some of our students, or may just be skills that they just really need to hone in on. And there's a real difference between, as all of us know, classroom learning and then applying that learning to a real project in the clinical environment. Another area that I saw the students needing a lot of support was with that critical appraisal of research. And that is something that JBI has wonderful tools to help us with and to help us do. So just the guidance in the application of knowledge from that EBP coursework into a real life project is really essential. So this picture is me with the 6 students that I supervised in that 2023-2024 academic year from Elmhurst. So just looking at that picture now, I'm really proud of them, and I can just look at them individually and tell you about all the wonderful things they're doing a year out from their graduate degree, which is really great. All right, so Melissa talked a bit about barriers and facilitators for employee-student projects, and I just want to expand on that a little and give some real-life examples from my experience as an adjunct professor. So we talked about that role confusion between being an employee and a student. So oftentimes that is kind of negated a little bit by having our employee students not be precepted in an area where they work. That is something that we definitely try to avoid. And having them kind of get into a different area of the organization so they can really see kind of the full breadth of what we do here. Graduate nursing programs also use a variety of approaches when they're teaching evidence-based practice. So here at Lurie Children's, we like to promote the JBI methodology. That might not be what they're learning in school. However, and I think Audrey touched on this in the beginning, what I often see is, all of the same elements are followed. We may just be calling it something different, using the name of a different model. But that is one thing that we do want to try to promote within the organization. So some of the facilitators, and Melissa touched on these as well, but our employee students can work on projects that directly benefit the organization. And I think Eileen's going to talk about that a little more too. And Brian mentioned it this morning too. So, hey, it's a theme now, but we really want to get our students to be working on things that are organizationally relevant and that are pushing our goals forward as an organization. Another great benefit is that project work can, and sometimes did in the case of my students, continue after graduation. So that is another excellent benefit into having our employee students here. So I want to provide a few examples, real life examples of projects that my students completed, and then we'll have some excellent examples from some of our students here as well. The first one was one of our MSN in education students. She was really interested in the psychological safety for nurse orientees and how the preceptor could create that. Her preceptor happened to be our manager of our KidStar Simulation Center. So she applied a simulation model to looking at how we can support psychological safety of orientees. So she had a lot of fun doing that. That is something that we are trying to continue today within our preceptor workshop. So she did a lot of work with our preceptor committee, put a simulation in place, and that continues today. So that is a great project. Next one is a little different. This was one of my clinical nurse leadership students, and so this one had more of a quality bent to it. But she was paired with a cardiothoracic nurse coordinator for her project and was looking at discharge optimization for our CV surgery patients. So she was actually doing a lot of what might have been considered some informatics work as well. So she really got to see something different because this particular student works in our ambulatory ophthalmology clinic. So this was very different from the work that she does every day here. So one of the other benefits, I think, is that getting these students, although they're in the organization, our organization is really big. So seeing different aspects in different areas of the organization, I think just enriches that graduate education. And then the last example, another one of my education students, she was paired with our clinical quality coordinator on the 19th floor, and they looked at fall risk bundle elements and how we can improve our nursing documentation of those through education. So she created a really wonderful educational session. She implemented that with the 19th floor, and I hope that they're still continuing that today as well. So. All right, so to kind of wrap up what Melissa and I have been speaking about this morning, we wanted to just address a few key takeaways. So the first one is that our graduate students are really important to what we're doing here at Lurie Children's. They help with our mission, and serving as a clinical site not only helps our organization, but it helps the profession. So I think we're really proud that we have the 60, was that the number you gave us? 60 affiliation agreements?
Yeah.
So we have our 60 affiliation agreements. And because serving as a clinical site can really help promote the profession of nursing. It also helps us promote leadership roles. It helps us retain employees and prepare employees that all important succession planning for the next steps in their careers. It also helps us recruit new talent. So we've got students that are from outside of our organization coming here as well. And we want to show them how wonderful our organization is so they can bring all that newly learned graduate knowledge and expertise here to Lurie Children's. And then, as we've mentioned a few times now, our student projects do help us achieve our organizational goals. However, important to remember that barriers still exist. So for everybody, listening online that's thinking this may be an issue that they're trying to solve at their organization, having that key point person like Melissa, who by the way has 3 or 4 other jobs in addition to that, I think is really key to manage the student placements, because as we mentioned, that lack of oversight of graduate students or perhaps not following that outline process can really set the organization and truly the student up for some risk. So, all right. And thank you. I think with that, Melissa and I would take any questions.
I have a question.
Yeah.
How many students do we get from the outside that are not employees? Because I'm much more familiar with seeing employees pursuing graduate studies.
We have, so I said like 60% of that 160 is internal employees, so about 40% are external. Most of them are either in the nurse practitioner program track, or all of our SRNA students are external to the program, to the hospital as well. But a lot of those really are our nursing education and nursing leadership students that are the schools are reaching out, because I have a partnership with the schools and point of contact. So, oh, you take our nurse practitioner students. We have a nursing education student, for example, that's really looking for a clinical spot. Is this something you can help us out with? And I'm like, I don't know, let's have a conversation. So then I have a conversation. So we know that we already have a contract in place, since I'm already taking students in through the other tracks. And then just have a conversation of what is it that you're really looking for? What is your project, and does that match something that we have here at the organization? And can I find a preceptor that has that area of expertise and can help you move that project along? So sometimes it works out and sometimes it doesn't work out if I can't find the preceptor.
I have one more question about the preceptors. When you have preceptors who identify willingness to be a preceptor, I know in the academic world, oftentimes they'll tell the story of the faculty and what their research is or what their operational interest is. Do you collect that information too, so that you have it readily available to try to align interests?
Yeah, no, that's a great point. I don't. I think a lot of the preceptors are my colleagues, so I kind of just know that information already off the top of my head. Or can I at least have an idea of, they're like, oh, I really want to do a project in the NICU and I want to do something developmentally. I'm like, oh my God, let me contact Sue. Or like, I really want to do something clinically in acute care. So I kind of will go by their area of interest, but I think that's a great idea to add and enhance to the program to have that information. Yeah, for sure. Yeah.
Do you have preceptors that ever reach out and say, I have a project I'm working on and I would like some help? Do you have a student who might be interested in partnering?
Like help with a preceptor or just help like
Help the project?
doing like, I need,
Yeah.
no.
Because that might be an interesting.
Yeah,
thing
I like
as
that.
well.
Yeah.
I had some projects I could use some help
Yeah,
with.
yeah, where do I have a whole list. I need help. You know, and I think sometimes that's one of the biggest barriers I see is I have people that reach out and say, hey, just because I work in the education space, that's my example, is like I have this education student and they really want to have hours. I'm like, oh my God, great. You know what? I can precept and I have like this whole list of like projects that I'm working on that would help me and help the organization, help our department. But then their school says, you know what, that doesn't really count for us. Like that, we don't want that to be, like that doesn't count. Or because I don't work on a floor, I'm not a clinical educator and they want someone that's a clinical educator or whatever rules that they have in place, then I have to say no because even though I have 10 projects, they said no to all 10 projects instead of being like, if that helps the organization and that helps the student, there's other schools that are really great with that, but not all schools are.
I would say too, I think we probably get a lot of requests from maybe some of the more popular, like areas. Like I get a lot of people that want to do STEM.
Yeah.
I know I get a lot of requests for I want to do something with new graduate nurses. And we may not always have, a project that is like graduate level or fits into like the mold of QI, EVP or something like that. I may need, my transition session facilitator journal updated, but that's not really something that is going to be a great graduate nursing student project. So I think sometimes, students come in with a particular expectation and maybe we don't have, the project or the resource to match it either. So Melissa does a great job with a lot of that, trying to figure out what the students' needs are and finding the right person. So, yeah.
But I think that's a great point. Like, how can we offer additional support to our students, maybe not just preceptors, but through JVI classes or whatnot. Food for thought. Yes.
I just, a comment, as we're thinking about, what our priorities are and our needs are as an organization, and then we're trying to have students fit into those. Sometimes I find issues with time. So maybe the student is an employee and they've identified a project that's probably valid.
Yeah.
And it may very well broadly fit into the goals. But at the same time, it may, from a timing point of view, may be all wrong. And we've identified as a unit our goals already for the year, and that just can't be a priority right now. And so we're sometimes find them redirecting around that, if you will.
Yeah, I think one of the other things I saw as a preceptor and a faculty member is these projects have to fit into this defined semester framework.
Yeah.
And it's really hard to have an implementation and to measure outcomes when you've got like a 3-month window to do it. So sometimes our students will come and they will have these wonderful ideas for projects. They're all nodding their heads.
Like,
Okay, great. They'll have these wonderful ideas for projects, but I feel like almost as a preceptor or faculty member, I had to kind of like talk them down a little bit, which I hated to do from their big idea, just so that they would graduate. I said, you need to graduate. But I think that is one of the benefits of having our employee students, because if you do have somebody who, maybe it won't fit into the time frame, but in the role that they're in, they could continue the work, that can be a facilitator as well. So, but yeah, fitting that into that semester time frame is really tough sometimes. Yeah.
More time.
And some of that is driven by the accreditation of the programs as well.
Yeah.
Like they have particular requirements based on their accreditation that the doctoral projects meet certain benchmarks. They have to have a plan for implementation, et cetera. And so that can sometimes be a barrier as well. And then the universities design their curriculum to meet those accreditation standards. So,
yeah, absolutely.
thank you guys.
Thank you very much to Casey and Melissa. That was very interesting. So next up to speak to us about administrative oversight of nursing EBP and quality projects is Emily Knights, and she has 13 years experience as a nurse, and for the last 10 years at Lurie Children's. And while working clinically, Knights served on the Nursing Professional Governance Board as the Nursing Quality Council Chair and developed the EBP QI Nursing Project Oversight Process. And since July of 2022, Knights has been Magnet Program Manager, facilitating the Department of Nursing and Allied Health Professionals Nursing Project Oversight Process. So thank you for that warm welcome for Emily.
Thank you, Sue, for the introduction. I appreciate the warm welcome. So today I'm going to talk about EBP, QI, and oversight. It's going to be about the nursing project tracker. I hope everyone in this room has heard of it. I know you have. I know Shirley Ryan has, because we presented on it at our shared conference that we do, Innovations in Clinical Inquiry. So it's nice to be back and talk through this process with everyone too, because I feel like each time we talk about this as a group and I present, I learn what other hospitals are doing, what other organizations are doing, and we learn a lot from each other. So today we're going to hit these objectives here. I won't read them out to you, but this is what you have to look forward to. So back in the very end of 2018, as an organization, we were talking about, within the Department of Nursing, we were talking about how are we going to develop a QI and EBP oversight process because of the challenges we were seeing here. We were seeing duplicative work in the organization. We were seeing a decrease in, we want to decrease incomplete projects. We were seeing projects that weren't seen through. Casey and Melissa mentioned this in there too. If you don't work here, some of those projects were falling off for our graduate students. So there wasn't sustainment of those projects because there was no true oversight of it. We needed a way to align big project work with what our strategies were as an organization. And so we had our preceptors talking to our students, sharing that information. But there was no formal review and approval of that process or those project topic selections. The other thing that was occurring at the organization was that we didn't have a formal way to review and approve dissemination of EBP and QI data, which is umbrellaed under business confidential information or business confidential data. And so we needed a process to capture when that was going to go out and provide that approval. We also had inconsistent leader awareness of the project details. So the project or the leaders didn't know what was happening in their area in terms of yes, they're working on a project on improving how we manage our central lines. But down to the specific, we're changing from this project or this product to this product may have not been included in that proposal when that student talked to the director about implementing it. And so the implementing an oversight process was a way that we are going to capture some of those details to make sure that an inappropriate product didn't get rolled out without full awareness of that. That didn't always happen, and that's the one-off, but in healthcare, we've got to protect for those types of things too. And we were missing opportunities for project mentorship. So projects were being started and completed, but maybe didn't have that methodological rigor that we were looking for as an organization. We want to have hefty projects, and so having an oversight process would be helpful with that. Now we had this process for nursing research, and so it was the Nursing Research Council who reached out to me as chair of nursing quality and the chair of our nursing practice council to say we're catching these QI projects that are coming through because mostly it's DMP students, but we can't keep reviewing these as a council. We're meant to focus on research. Do you want to take over the QI review process for those projects? And so we're yeah, what a great idea. But wow, is that an overwhelming thing to think about when you haven't done it as a council before? And I think as an organization, we do great with the volume of nursing research projects that we have compared to other organizations. But QI and EBP we knew was going to be those numbers, and that volume was going to be a lot higher. So we had to really make sure that we had the process in place before we're okay, we'll take your projects now. So we started
a journey, I would call it, of developing a nursing project tracker, which would be then the process that we use for oversight of QI, EBP, and then we would transition that existing research process into a nursing project tracker too. So that is the story of how we started our journey to that, and we developed the nursing project tracker. So it is an online tool, it's a digital tool that we use to help formalize the review process and track how nursing projects are going in the organization. We do have approval steps built into this process, and so that provides that organizational awareness and leader knowledge of what's happening. We also use it to protect our professional practice as nurses. So any changes to nursing practice through that ECP process that happens goes through our nursing project tracker process. And so they get approval from the organization to implement changes in those practices. It is our councils that review. You can see some of these are in progress already. This in progress, that means they've been approved by our councils who have that oversight of our nursing practice. And so in that way, we've got a way to protect our professional practice and our practice environment. Because some of these QI projects are about engagement and protecting nurses as we do what we do. So I'm going to go in a little bit about the functionality of it so you understand how the oversight is built into it. The first step of the review is I have an idea, and so you go into the nursing project tracker. That is a list. I've left it here. You can't really see it here, but there are the search bar, so you can search, and it'll look at the abstracts and the titles. It'll search those for the keywords for the projects. So you can see if there's another project happening in the same area you want to do it or in the same topic. So you can retouch the project lead and say, is my project idea too similar to yours that we would be like in conflict with each other, or are they complementary projects? But can I take some of your lessons learned so I don't have to start from scratch? Do they have an evidence table you can build from without having to restart the entire evidence table too? So it's helpful in that way. So if there is no duplicate and you can move on, then you submit your initial proposal, which is just an abstract. So it's like a brief description of what you want your project to be on. That you submit to the leader in the area where the project is taking place, and that leader will review the project to make sure that it's in alignment with what our priorities are for that area, what resources are available. If you're facilitating a project in the area where you also work, that leader will also know your capabilities as a project lead and maybe provide more resources, like the resources that you need from a professional development standpoint to facilitate projects. So it's helpful in that way. So after you get that initial approval, then that's when you do like all the digging deep. You get your details and you do all that full proposal that has all the details that you need to implement your project. So this is how, when you submit this full proposal, that the leader knows this is the intervention that's going to take place on my unit. And yes, this is in alignment with our practice. Yes, there are changes coming down the line, but this change is still in alignment with the changes that are coming. And so it's important for leaders to take those two opportunities to review the project to help with some of the challenges we were talking about in the previous presentation. After that, after the leader approves that full proposal, that's when it goes to our councils who review QI. Will go to Nursing Safety and Quality Council. They are QI experts that are learning. There are members that are experts already for QI, and so they review that methodology. And then the newer members are learning how that stuff works, but they do it together. So it's, in a way, it is both like, yes, you get the QI methodology expertise, but also members of the council are like growing into that expertise as well. So it's helpful for our council members too. And once you get approval from our council, then it can be implemented in the organization. So that is the overview of the process. After it's in progress, that's when you submit for your dissemination review and approval, it's great that it's associated with projects, but also causes some issues that we'll talk about in the next few slides. And then you can also mark your project complete. So once your project is done, you're like, this is ready for the archives, you can mark it complete. Some projects like QI will go on forever and ever. And so it's kind of tricky to decide like when it's done, because we're never going to be done working on falls with injury. We're never going to be done working on collapses. And so Just keeping in mind, you can complete the project, but you can still submit status updates to that. So if we're making different changes, you can still upload those even if completed. On the left-hand side, you'll see that they have project guidance. This is meant for the project lead to tell them what's happening with their project or what they should be doing during that time too. So there's a little bit of instruction built into the nursing project tracker, but not a lot. These are the types of project reviews. I already went over this a little bit, but we didn't go into the review time. So the leader for that first approval, just like that brief paragraph, is 3 business days. The leader should already kind of be aware of that the project or someone's thinking about the project, but sometimes we're finding that the leaders are not aware of it, and the project lead or the student just surprises the leader with saying, I'm going to do a project. And so they've got 3 business days to review this, the lesser amount of information. For when it's that full proposal, the leaders do have 5 business days to review it to give them a little bit more time to look into it. At this point, though, the leader is aware of it because it's our first approval. And the project lead has been working on it, so hopefully in communication with the leadership in the area. Again, the communication doesn't always exist, so it's really helpful to have this leader review too. The council gets 10 business days because the way that our councils get review or feedback is they send it out to a group of clinical nurses, 5 to 6, but gonna increase that now. So they have time to read the reviews within, like, take the time to read the reviews, put the feedback in. Our council chairs compile that feedback and send it out to the project leads. So that's why they get a longer time, that 10 business day time frame. I have not seen this really slow people down unless they wait until the last minute to put it in, because projects take way longer than, what is this, 18 business days to complete. So we have not seen it slow down unless they're behind on their game, which happens too. I want to highlight over on the left-hand side what our council's looking for, because we went over what leader is, but our council does do that methodological rigor, but they also see more projects than our leaders do, so they may be more apt at identifying what projects are duplicative across the organization. They also are familiar with workflows in other areas, because it'll be nurses from different areas reviewing each project, so they might identify like downstream impacts that weren't picked up by leaders. So it's really helpful for our council to review those projects too. So we have some infrastructure to help with this nursing project tracker and QIVP oversight. We put it in place because while it's great to have a tool, you can't just have a tool. You have to have a way to use it. You have to have a way to drive people to it so they actually use it. And so that is what our infrastructure is meant to do. We have our leader and NPGB chair preparation. So this is sitting down with the leaders, showing them how the nursing project tracker works, showing them what they need to do to review a project in their area. We give them guidance on what to look for in that project reviews, like on our previous slide is the information we give them. They also have things they'd like to see in their own area too. So each leader takes a little bit of a different approach to it. Our NPGB chairs are pretty good at handing off from one person to another. The previous chair will work with the oncoming chair. We also have that chair co-chair model, so you do get some of that succession planning in. I'm also a resource for the chairs too, who are reviewing the projects. I keep looking at these two because they're chairs right now. Reviewing projects, that is helpful for them to have an additional contact. So we are also talking about the interdepartmental force functions that help drive users to the nursing project tracker. So the one we have in place right now is for our data insights and AI. They just changed the name, so I'm so sorry. But they're our data analytics department. If you submit a request for reports through them, they will look to see if your project's in the nursing project tracker, and if it's not, they won't go through with your request until it's in there and approved by the leader in the area. They have a ton of work to do, and they need to prioritize which reports to focus on. And so this, in addition to talking with nursing leadership, is how they prioritize nursing requests and things like that. The nursing project tracker facilitators used to be plural, but now it's just me. So what I try to do is I'm the people associate me with the nursing project tracker most often, I'm trying to emphasize that it's our chairs who are like the owners of our nursing project tracker. I help with that day-to-day facilitation because they work clinical as well, so don't have 100% of their time focused on helping with this. So I also am trying to meet with each person after they hit that initial approval. So after the leader gives that first approval, I'm trying to meet with each project lead to make sure that they've got the templates that they need if they don't have school templates. Let them know what the expectations are from the nursing project tracker standpoint and from an organizational standpoint in terms of like, we need to build a project that's meaningful. We need to have a sustainment plan in place. Like if you know you're graduating, you know you don't want to continue working on this project afterward, make sure your project materials are organized in a way where you can hand off to someone else so they can do it. And so people can come back and learn lessons from what you've done too. So it's helpful in that way. And then the last, and I think the biggest part of our infrastructure is our oversight, our NPT oversight committee. So the purpose of our oversight committee, they are the decision body, the decision-making body that provides oversight, ensuring its functionality and process effectively enhance professional practice and professional practice environment at the organization. It's made up of our Nursing Professional Governance Council chairs of the councils that review projects. So right now we have 3 of our 4 councils reviewing projects, so those chairs sit on it, along with our Nursing Professional Governance Board, so the whole thing. Those chairs sit over it because they have ownership over nursing practice. We also have an APP, what was your official title, like liaison? Yeah. But Audrey's been a great member of our nursing practice, or nursing project tracker oversight committee member too, because she's got the JBI knowledge, which is really helpful in terms of like looking at projects at the organization. And so what this council, or I'm sorry, what this committee does is they make decisions about the nursing project tracker. So the ways that we use it, what changes can we make to the nursing project tracker? And so that gives them ownership, even though I facilitate, they make decisions on it. I am a member of the committee, so it's not like I don't have a say, but it is decision-making with the committee. They help us brainstorm ways to drive users to the nursing project tracker. They help us identify opportunities to bring recognition to nurses who aren't doing work in the nursing project tracker too, because that's one of the initial purposes, is finding a way to bring recognition to people working on projects or working on anything that is not a part of their clinical. And then just ways to improve the nursing project tracker. It is going to be a continuous work in progress because we always want it to meet the needs of the organization instead of just being a stagnant tool process. We want it to continue to grow in the ways that we grow too. So that is what our nursing project tracker oversight committee does. Go to the next one. One of our always challenges is what I think I'll call it, is utilization. We've already talked about driving users to it. So you can see on the screen, this is a snapshot of the projects that are in there. So since the nursing project tracker was implemented, we've had 576 projects entered into it. Some of those were entered before, they were like preloaded before it went live. So we had about, I want to say 250 projects in there beforehand. And so the ones implemented since then, I think are about not the 245, I want to say that because I see it on the screen, but somewhere around there. And Melissa mentioned down at the bottom, 76 projects because there were 4 school projects already in there before it went live. So Melissa shared the number 72 school projects. And then she said that there are 160 students a year. So we know that there are projects not being captured within the nursing project tracker that should be going in there. And so like in conversation with our leaders and the nursing project tracker oversight committee, we are trying to drive people to it because this is the way as an organization we've decided to have that oversight for EBP and QI projects. It's always a challenge. We work interprofessionally, interdepartmentally. And so because of its title, I will say is one of the driving things in nursing project tracker, people ignore it if they're not nurses, which is not what we want. So that was, I would say, a design flaw. Now I'll say that and take ownership because I was part of the design team. But you can see 576 sounds like a lot of projects, but we know that there's still a lot we are not capturing. Most of the projects that come through have been QI. EBP is a lot of the ones we preloaded, and these were the resident, the RN resident projects. And so the ones being entered though, like after implementation, after go live, have not been the EBP projects. It's QI that by far and away dominate the number or the types of projects that we see into the nursing project tracker. We can also keep track of the status, and so one of the manual things I try to do to help with the relevancy of the nursing project tracker is get people to update the information after they put it in. So like getting them to the nursing project tracker is the first hurdle. The second one is to continue throughout the entire process, including after their project is in progress, providing those updates and eventually closing out projects that can be closed. Next, we'll talk about the successes that we've seen. So we have seen improved nursing ownership over nursing practice. So things are coming to the councils before that weren't previously coming, and they're getting the opportunity to provide feedback on things that they weren't able to before, which is a win from a nursing professional governance standpoint, and I think the profession. We have caught some duplicate projects before they go into full motion. So some of our leaders who are more active than others in the nursing project tracker catch it at that time, at that first leader approval. They're saying, we've seen this project before. Some of the projects get a little bit more down the line before we say, this is sounding familiar. Let's take a look at the nursing project tracker and we'll see that. Sometimes these projects are developing simultaneously, and so it's hard to catch it in that way, but working on, we've had success, but not 100% success. The next successes are providing meaningful feedback to project leads. I've had multiple leaders say, and not all of our leaders are trained in QI or EBP methodology, and so when they get that feedback from councils, they find it very valuable because they get information that they hadn't thought of themselves or maybe hadn't been reviewed with them before. And so our project lead, they are thankful for what it is. And even if their project is fully formed by the time it gets to the council and they get that approval, in their like PDSA cycles, they can implement, or if they're not seeing the change they want to see, they can refer back to that feedback to maybe say, oh, maybe it's because we didn't consider this, and they can take that feedback and incorporate it into their project or their PDSA. So some of our leaders have been very grateful for that. It's also increased organizational awareness. So you saw on the previous slide, we have these reports so we can say that we are facilitating an astounding amount of QI projects. Why have our EBP projects dropped off the number of EBP projects? Because we should be looking at that evidence and incorporating it. So in this way, we can advocate for resources in what we need to help professional practice here at Lurie Children's. So having that organizational awareness is important. The nursing project tracker is something we can also pull from for the magnet documents as we write about the nursing accomplishments throughout our 4-year designation or our writing window. We also use this information for the nursing report, which we put out every 2 years, which also captures short stories about what nurses are doing in the organization to share externally and internally. So that's another way that we bring recognition to nurses. Our challenges, which I won't say perpetual because I will be optimistic, but ones that have like stuck around at least for the last 2 to 3 years since it's been implemented. Interdepartmental utilization and support of the oversight processes and consistent. So we do have other teams that do direct their people to the nursing project tracker. We've got a lot of our clinical research professionals who do use the nursing project tracker, even though they are not nurses. If there are projects that are being led by nurses, they will put it into the nursing project tracker, which is great. But then there are some areas that a lot of what they do is facilitate projects. And so it would be helpful if they were more involved entering projects into the nursing project tracker or appointing their project leads to enter projects in there. And because a high number of these projects are facilitated outside of the department, they think that their project doesn't meet the criteria for submission, when in reality, it probably does. right now, the way that we have dissemination review built into the nursing project tracker is that it has to be associated with the project to be submitted for dissemination review. We know not everything is a project, not everything's going to be in the nursing project tracker, but some of that stuff should still probably be reviewed by our data trustee or the way that he has designated that we will approve that dissemination of data. And so one of the things we learned after we built the nursing project tracker is that we should probably unlink the dissemination review process from projects, still have a way to link the ones that are associated with projects, but have an independent way to submit those projects so they can get that review without being a project. And so we're not capturing all of the data that we want to see going out into the world. Not so that everyone's willy-nilly sharing, they're asking people in their areas that they know, like, will you review this before it goes out? But it's not following the process that our chief has set up for us. So the need for organizational triggers, this is like referring back to our data analytics and reporting team, how they look at if the project's in the nursing project tracker to approve their reporting building. We need more departments to do things like that. So what we've come up with so far, and we have to talk to these teams, is maybe our nursing informatics team, if anyone wants to make a change to like our Epic flow sheets or from our EHR, maybe they've got to look into the nursing project tracker, and if it is a project and it's not in the nursing project tracker, they tell the project lead before we're going to make any changes to our EHR, we need you to get approval from the areas this will impact, and do that through the nursing project tracker. So that's the way we can push people into using the nursing project tracker. The other one was, I was just thinking about it yesterday and I can't remember what it is. I know Melissa's helped a lot with the graduate students, so I speak to the people that she works with to tell them about the nursing project tracker. She pushes students towards the nursing project tracker. If something pops up in the nursing project tracker and it's associated with the student, I make sure that they have that affiliation agreement, because sometimes they haven't gone through Melissa. Like she was talking about the challenges with adoption of what she needs. We help each other because she helps with NPT adoption utilization too. So that's a nice partnership. And we need more like that in the organization because we really don't operate independently from each other. So if we can help each other out, we can help each other accomplish each other's goals. We built this tool from the Power Apps in the Microsoft suite, so it was limited by what was available then. There are a ton of tools that have come out since we started developing this in 2019 that we could be using to help with projects that we are not. JBI is an example of that. We were not partnered in 2018, right, with JBI, or were we?
Yeah.
Not yet. Either way, that's like an example of a tool that we could have used, because I know they've got some methodology tools that we could have used. Open synthesis is another tool that's come out that provides a lot of the similar functions to nursing project tracker. Not the same. I will say we do have some unique things that they do not have built into it, but they also have things that we don't have and that we won't be able to keep up with from the one person in IM that's supporting the nursing project tracker. He's not going to build in like a whole synthesis tool and that type of thing. So if we want to keep up with what's happening in the profession of nursing, using a homegrown tool might not be the best option for continuing. It's what we have right now and we're working on it, but we are always open to how can we make this better? What's going to be best for our nurses? What's going to be best for nursing practice? So the challenge is everything's always changing and growing, which is a good thing, but how do we adapt it and incorporate it into our QI and EBPO process? Questions?
Somebody that's interested in seeing more of our students, in particular our DMP students, do more dissemination of their work. I mean, there's been some fabulous projects that just have not gotten out in the world.
Yeah.
What is the current procedure for having that work approved before it goes out? I mean, I know they present to their school because it's part of what their requirement is, but beyond that, I know the research projects are handled differently, but the QI BP are typically what we see at the DMP level. And so what is the current recommendation for approval of dissemination there? Particularly publication, posters at conferences, abstracts at conferences, things like that.
It starts with putting your project into the nursing project tracker. So once you've done that and your project is in progress, that's when you'll get the option on the right-hand side of the tool. If there's a disseminations tab, so you upload what you want to disseminate. Now, beyond that, there isn't anything built into the nursing project tracker process that will help with dissemination. So I think you want something more like who tells these students, like who recommends journals to submit to?
No, I'm thinking like who approves organizationally, who says, yeah, that's okay to send out? And does it have to be, here's the data I want to share in my paper? Or is it that I have to have the full paper written? And does that go to somebody for them to bless it before we send it to a journal? That's kind of where I'm at with that.
Yes, it should be fully formed and developed, and the way it's built into the nursing project tracker is you upload an attachment, and that's what gets reviewed by our dissemination reviewers. The dissemination reviewers are identified by Brian, our chief, and so
Sure.
I'm trying to think off the top of my head. I think Karen Carroll's the dissemination reviewer. They're identified in the nursing project tracker, so whenever a dissemination reviewer has a dissemination to review, they get an automated email letting them.
I see. So when you put that in, that would automatically trigger that.
Yeah.
Okay, just, that was one process that was not as clear to me as the others.
Oh, yeah.
Thank you, though.
They go in and review it. Our dissemination process doesn't run as smooth as I'd like it to. Doesn't run smooth, period. So I think that's something that we're working on. Stu Warner has probably like maybe our #1 user of the nursing project tracker. She submitted a lot of disseminations, and so she's very familiar with our tool. And probably most familiar with our dissemination. You're probably the person most familiar with dissemination, although other users are too.
I just put on my to-do list monthly, update the project tracker so that.
I can send you the name of the list of dissemination approvers too. I have to look to see the exact list.
Yeah, that
would
would
be
be
you. Yeah.
Yep.
We'll do front first.
I just have a question as far as, first of all, I love the nursing project tracker. I think it's great. I have 2 success stories I can share with you later because I want you to hear those. But my question is kind of on how do you keep the project tracker kind of quote unquote cleaned up? I would assume that a lot of people put projects in and then maybe they never finish them or they never come in and update them. And I'm assuming that, I mean, organizationally it'd be great to have that data, but it's also great for things like Magnet. So is there a process for like, you know, I hate to say hand holding, but like checking in with the people that have put their projects in to see, is this still happening? Are we done with this? Should we take it off the project tracker? What does that look like?
So right now, the only process is manual. Like I would have to go in and like maybe I can pull like a detailed report and email each project lead for the projects in progress saying it's time to provide an update. That's not what I'm gonna do though. We have a ticket with IAM right now, and so our one IAM person is building automated emails to go out every 3 months after your project is in progress saying, please provide an update to your project. So while it won't force people to do it, at least it's a reminder you've got a project in there that's open and it looks like you're working on it from what we're seeing. So please address it. And then we're also looking at approvals for leaders. So sometimes our leaders don't if it's the first project they reviewed, they may not recognize the nursing project tracker email address as something that they need to look at and like take action on. And so we've got the leader approved reminder emails going out too to help projects not get stuck in that approval process. The other thing is I've started meeting with areas individually. So I'm trying this from both a Magnet program manager standpoint and nursing project tracker facilitator. We're meeting every 6 months to talk about data performance in their areas, Magnet things, but also what are your open projects in the nursing project tracker? Can any of these be closed? What projects aren't in there that need to go in there? And that's helpful for Magnet too, because I can identify possible stories to write about. So those are the 2 things that we're currently working on.
Yeah, it's huge. So
Yeah. Yeah, because we don't want a stale project list.
Right.
It should be living and always updating. Michelle, you got a question?
Oh, yes. I don't know if you know this off the top of your head. I think I've seen a Power BI where it says like total number of dissemination.
Mhm.
Do you know, like in terms of closing the research to practice? Do you know like the percent of completed projects that have a dissemination
Mm.
plan? Versus just like dissemination?
I could probably get that information from pulling the underlying data of the reports, so I can look at the status column, filter for completed, and then see if there's a dissemination associated with it. So off the top of my head, I don't know the number, but I think it's something that I could get. It would be a manual process, but if you want to know that, I can get you that information.
Yeah, it seems like maybe an area that like we as a council or as an organization, we could help support making sure that the completed projects also get disseminated. That might be.
Some of the other tools that we talked about, like the project oversight tools, have dissemination features where you've got your project information in that tool, they can generate a project poster, they can generate things like that. So there are things we could be doing and tools out there. We just need to find a way to have people use them in a way that's meaningful.
And just to comment, I don't think, like a couple of my projects are not listed as completed, but I've done dissemination because I've left them open for secondary analysis of data. So they don't show up as completed, but there's been dissemination. Does that make sense? So I think there's some of that going on too.
And part of the flaw of the design is that you cannot submit for dissemination unless your project is, oh no, you can do it in progress.
Yeah,
I was gonna say you
done it.
can't do it, okay. Never mind. Other questions? Don't feel bad if your project's on the nursing project track there. Sorry to look at you guys directly. It's a common thing that we're working on. You can see all the challenges that are preventing it, so you're not alone out there.
And can they be added after the fact?
You can add projects retroactively. The only thing I ask you to do is like email me so I can just let the councils know you're reviewing a project that's already in progress. And so when you're providing your feedback, keep that in mind. That way the project or the feedback is still meaningful when they get it. Maybe I should have done it.
Great. Well, thank you, Emily. Every time I hear about the project tracker, I learn more about it. So it's a complicated process. So next, it is my pleasure to introduce Eileen Romano. She's going to speak to us about integration of organizational priorities and student academic work. Eileen is a DNP prepared nurse who's worked at Lurie Children's for 25 years. She was born here. Her DNP from Ohio State University, focusing on executive nursing practice, EVP, and implementation science. Eileen is currently director of patient care operations, managing an inpatient floor that serves patients admitted for neurosurgery, orthopedic surgery, neurology, research, and endocrine needs. The inpatient floor also supports epilepsy monitoring and clinical research units. Eileen is a strong supporter of using evidence in practice and mentoring others in making evidence-informed healthcare policy and practice decisions. So help me welcome Eileen.
Everybody. So my focus today is to speak about our journey in developing our approach, really being more methodical in getting evidence into practice and with evidence implementation. And specifically today, we're going to talk about the success we've found when supporting graduate students' academic experiences while also achieving organizational priorities. Next. And so here's my objectives today is to talk about evidence-based practice models and implementation strategies, to identify challenges in our early efforts supporting evidence-based practice projects, acknowledge what's important to leaders and mentors, and to identify the benefits of student projects being chosen based on aligned interest with organizational priorities. So why be evidence-based? There is so much literature out there that captures the fact that when you are evidence-based in your practice and your decision-making, that you enhance quality of the work you're doing, you improve patient outcomes, you reduce costs, and you empower your clinicians who really feel a higher sense of what their contributions truly are. And this is the quadrupling of the IHI. So being evidence-based accomplishes that. Lurie Children's brought a team from Ohio State here for an evidence-based practice immersion back in 2017. And it really ignited the passion of a core group of us who, really realized that attending to bringing evidence into practice was probably the most important thing we could do for our nursing practice and for the profession as a whole. It compelled me to enroll in the DNP program at Ohio State when I realized that, I thought all kinds of things were going to change when we had done that immersion. And then I really realized, the organization as a whole may not be completely ready to support that. And what can I, as an individual nurse leader, do here to try to help promote that and to develop it and to move it forward? So that's been my goal ever since, in trying to be more methodical in applying evidence in our practice. So what we have here is, whoops, go back one. There we go. So what we have here is is the first model we learned during that immersion. It's by Bern Melnick and Ellen Fino Overholt. And what I really like about this evidence-based practice model is that it's really simple and it gets to the heart of it. And when we've heard people say that they recognize the patterns play over and over, it's true. Like, I almost don't care what evidence-based practice model you decide to work with, just pick one, because they all basically have the same elements. But on this one in particular, I was really drawn to the step 4 about integrating evidence with clinical expertise and patient preference. And it doesn't necessarily say implementation, but I knew that this was the actual doing of it, getting the evidence into practice. And it was the thing that really I felt I needed to key into. And what I was recognizing was this whole concept of implementation science and how do we implement, and specifically in a larger organization. Like I said, there's many models, and in that effort to understand what goes into the implementation of evidence, I was really drawn to the Iowa model because they really spend a lot of time on that. And it, like me, you've read the books on them. The Iowa model textbook, like 2/3 of the book is dedicated to the implementation. There is a lot of information about it. And I feel like truly it is the most difficult step, but also really intriguing. And of course, it aligns with what I do every day as far as guiding operations. But what I have found over these last couple of years in working with these amazing students and some others in the prior year is that I didn't fully appreciate, and I had my attention drawn to this concept of is a topic of priority. And again, the Iowa model really focused on that. And actually, I'm going to give a close-up here. So is the topic of priority was like so important, like if you click again, I was like, wow. It- Someone might think that the project is a priority, and it might be a priority to them, but it must be asked whether or not the topic is a priority to the mentor that they're going to be working with. And is that mentor a leader who can help shepherd it through and knock down the barriers that it's going to encounter? And when the student's effort and the mentor's effort align, and when that also aligns with an organizational priority, that project really blooms. And I love yellow flowers. So I went to that. So truly an evidence-based practice project should not move forward unless the answer to that question about whether or not the project is a priority is a resounding yes. All right, I'm throwing this in because along with the Iowa model, Cullen and Adams drafted this, which is a supplement to the Iowa model, and it gives further guidance for implementation strategies. So what I really love about this is that the top end of this model provides implementation strategies that are relevant to individuals, and the lower portion talks about implementation strategies that are important to organizations as you're working to get evidence into your practice. A couple of vital implementation strategy resources that I do not have on here, but I do have in my reference slides are the expert recommendations for implementing change, or the ERIC project that happened. There's a gentleman named Byron Powell who pulled these together with collecting a lot of experts on evidence-based practice, and through a Delphi process, they really narrowed in on what are the things that we're using that actually are effective, and they came up with 73 of them. One of his colleagues, Cynthia Perry, in 2019, did a revision, and I believe there's even another revision, but I didn't find that one for us. But there are some, like if you read the list of the implementation strategies, you would easily recognize like these are things we do. So we talked earlier in Audrey's discussion about audit and feedback being very important. We know that the vast majority of projects that are happening, the way they're able to be sustained is by audit and feedback. Education seems to always be a huge part of what needs to happen. So there's a core group of implementation strategies that we use again and again and again, but there's all sorts of ideas in there that it's really fun, I think, to have a menu of items that you can look at and choose from to figure out what works best. All right, so as we know, Lurie Children became a JBI affiliate with a core group who trained to be systematic review trainers, and we have folks who have actively conducted and completed and published their systematic reviews and scoping reviews. And the JBI models agrees also with the concept of assuring that a project topic is an organizational priority. We learned earlier about the JBI model, but I'd really like to focus on the evidence implementation section and those little wedges on that outer side that give it more depth. All right, so JBI's guidance for evidence implementation has tabs a focus for context analysis, facilitation of change, and evaluation of the process and outcome. And the focused activities that it walks through are meant to arm key stakeholders with evidence to inform their decision-making for sustained healthcare delivery improvement. All right, so the little wedge, context analysis. So in analyzing the context, to me is kind of like a little SWOT analysis, and you have to ask a bunch of questions. So what's happening in this environment? You know, like what's going on that this is a problem right now? You know, you got to get to the dynamics around it. Are there internal and external factors heightening the focus on a particular issue, which really make it right for a project and make it right now? You know, what makes that issue a priority right now? And if it's something that needs to be solved by going outside of one particular area or crossing areas, then is the organization as a whole ready to support the project in addressing that issue? So like I said, many of the evidence-based practice models, you know, I think at different times, different elements of it kind of screams at you a little more. And this is where you really need to make sure that you've spoken to the different stakeholders to make sure that even though you've got maybe a project leader or student or somebody who wants to run a project, you've got a leader that it's important to. But again, if you're going to cross areas, is it important to all the leaders across all the areas? And how do you assure that and tap into that? All right, facilitation of change. So anybody who is going to be a project leader really needs to have good facilitation skills. You have to be informative, you have to be motivational, you have to be a good negotiator, and you need to foster team development and participation. How do you get others interested? How do you heighten a sense of urgency around that particular issue so that people do care? All right. Evaluation of process and outcome. Systematic approaches to practice change should include what will be monitored and how it will be monitored. What data are we going to need and how are we going to collect it? How will change be sustained? How will problems along the way be identified? And how will mistakes be caught and feedback provided? Donovan principles, which I use that framework constantly, structure, process, outcome, suggest that evaluation should really focus on the impact of changes to the structure or processes of care as well as the outcome. So, you know, if we have our eye on the ball of a better outcome, what are the processes and the structures that have to be built or designed so that you actually get what you're trying to get? I mean, it's, you know, what are you putting in? What are you getting out? Drawing on existing models and theories about change management and knowledge translation. This evidence implementation wedge of the model seeks to ensure that this process is informed by and relevant to the local culture and context. So again, really have to know what's going on in the context and you know, whether people are going to be receptive to what you're going to be proposing and doing. All right. All right, so our early efforts. So after our evidence-based practice immersion back in, like I said, 2017, we focused on teaching and supporting our nurse residents in the process of evidence-based practice. We really saw that as kind of our, you know, a ripe area that we could really focus on. And we weren't alone in that. That happened across the country. And it slowly came to dawn on us that that shouldn't be the only group that we're looking at. We had, at that time when we were doing it though, we had nurses develop their own ideas about what was interesting to them in their areas. And we had them complete literature searches and then select, appraise, and synthesize the evidence. But the residents then determined what actions could be taken, but it was all the way at that point in it before, really the leaders of the particular area that would benefit from this effort were kind of brought into the discussions. And we were kind of surprised that things didn't just take off and go then at that point. And it was really because the stakeholders had to be brought in way earlier. Another issue we had is that we had so many nurse residents who had so many different projects that we were running out of mentors who would be willing to do all of that. And then on top of that, like I said, the key stakeholders were brought in pretty late. But it kind of got perceived as it was extra work that needed to get done, as opposed to just a continuation of the work in a more natural flow. So, so the project objectives for those projects at the time were rarely priorities for those area leaders. And so the leaders didn't advocate maybe as well as they could have if it had already been a shared priority. The difficulty with that then was, of course, that those evidence-based practice projects, regardless of how amazing and wonderful they might have been, it was extremely rare for them to move beyond evidence synthesis. So my partner Casey in that work and I were really pondering that, and what do we need to do to make that a better scenario. So, and all right, so our organization works closely with an outside university, and Casey already detailed that really beautifully. So Elmhurst University has an on-site MSN and DMP program here. And so we have the benefit of employees who are pursuing graduate studies participate in that. And so it's an amazing resource for them to be able to develop professionally. But they also have a great understanding of the operational challenges and needs that are going on, not only in their areas, but in other areas as well, as they connect with their mentors and get to know what's happening there. So anyway, we're recognizing this. Like I said, a couple of years ago, I came to be like, oh, this is the next best place for us to be looking at. How do we align student effort to the benefit of operational gain? But when we first, again, started to kind of focus on that group, we kind of encountered the same kind of pattern where it was like, even though people really love to mentor, it was still kind of looking at if a student comes in with a preconceived notion necessarily about what project they want to do, and it isn't something necessarily important to the leader who's going to be the mentor, then it's always going to feel like it's extra work to somebody. And so I don't know about you guys, but I don't have time to do my work once, much less more than that. And so, I knew for myself that as I was mentoring different students, that I needed to really pull them into the things that I was already passionate about, because by creating that symbiosis there, I was advocating for them by just advocating for the project I was trying to attend to. And it instead, which I also had experience with, was just trying to help that student champion whatever it was they were trying to achieve, but it wasn't important to me. I wasn't as keyed in because all of my priorities was pulling my attention away. So I thought this, in order to be a really golden thing and to take advantage of this, university offering this, as we noted, like to get the assistance we need to actually have farther reach and support and to use this. I mean, our students have required hours that they have to spend doing things. It might as well be in something that's really going to make a huge difference and really help propel our organization forward. All right, so we needed a mindset change. So what are the leaders' priorities in serving the organization? So hence my question to Melissa is like, how are we doing that? And what I remember in my various experiences in training at different steps in my career is seeing faculty bios where you can be like, oh, that is, I got to go meet this person because they're doing research in this area and this is something I'd really like to impact or have a hand in. I think that's an opportunity for us here. We can do maybe a little bit more of that. Yeah, I think that what I did, Megan Giles was a student who worked closely with me, and I heard the thing, we just had a frank discussion about what are the things that you're interested in doing, and is there a way for me to connect you with those folks? And then, maybe those folks weren't as far as needed to be to suit the student and her interests, and her interests kind of have kind of a behavioral health spin on it. Well, I have this massive project that I had to accomplish around improving our processes around the use of patient restraint for violent patients or aggressive patients. And we just had a lot of work to do to make sure that we were compliant and people understood it and knew what they needed to do in the moment. So I was like, well, this isn't exactly behavioral health, but it sort of is. And so we kind of negotiated that, and she agreed to act as a project manager because that was in line with her program. And so when we aligned nicely that way, we really got a good headwind. In a prior year, I had another employee, graduate student approach me and say, hey, I'm really interested in, attacking acute kidney injury. And I said, well, then you're gonna need a different mentor because I run the neurology floor and we don't have kidney patients on our floor. So can I help connect you with somebody? And she was like, well, no, I'd really like to stay with you. And I said, okay, but then we need to revise our policy on diabetes technology. And so we did that instead. And again, like I want to just really drive home the win-win that can happen that way. In that situation, we went from only having a policy about insulin pump use to including, and expanding that policy to include continuous glucose management. It exposed that student to the entire endocrine team. And post-graduation, she is now an MP in the endocrine group. So it's, there's just so much, and she didn't really know she had that interest to that level. But it really, caused something to blossom, and it ended up being win-win all around. And we're going to revise that again, and she's going to be involved. All right. So anyway, I did not read you all the squares, but I am fully confident that you can also read. So we'll move on. But that's my concept of the mindset change is instead of just accepting whatever it is the student brings to you and says, this is what I want to do, negotiate and shape that together so that there's mutual benefit as you go. So, and then nobody's doing something extra. You're in line and you're, talk about rowing in the same direction. It just makes all the difference. So a leader acting as a mentor is really helpful because we're really invested in the outcome. And the leader mentor should consider the actual work they already have responsibility for completing. And this should be shared with the student to determine what efforts align. And together they figure it out. So I just wanted to bring us back to the original JBI model. And in the center of that JBI model is their pebble. And if you've ever gone on the JBI website, it has this cute little tune and you see this little pebble like hit the water and you see all the ripples. And that's really what I see it's all about when you're acting as a mentor and you're trying to get evidence into practice is what impact can you have? And for us, harvesting these graduate students' efforts, it's absolutely going to improve the lives of our patients and families, but it's also going to make our organization stronger. So with that said, I wanted to speak a little bit about our students' projects that are, we're going to hear a little bit more about, a lot more about. So I feel really fortunate that we have these wonderful nurses who decided to do these projects on our floor, on the 19th floor, and also with our nursing professional governance group. So you'll be hearing from Kylie, who was doing the education track, and in looking for a project, I was being the advisor to our protocol and procedure group, and we've been working, and we spoke last gLocal about our adoption of the Lippincott suite of products and the Lippincott procedures. And we've been working really hard on that over this past year. And Kylie agreed to work with the chair and co-chair of that committee to develop that education that all our nurses will be participating in taking this week. I think it goes live. And demonstrating on how, again, in the ripple, will really help us in decreasing our hospital-acquired conditions. Melanie is amazing. She was so innovative in, again, fashioning in education. Every year on the 19th floor, we do some mandatory nursing education, and Michael Olson, who is here, who's our clinical quality coordinator on the 19th floor, does a fantastic job of looking at what are the priorities that we need to attend to on our floor based on what kind of safety event reports do we see, and works with our educator, Callie Hutton, to really help hone in on what's going to be the most important education we provide to our nurses. And in comes Melanie, who is working with Michael, and we needed to focus on education around our external ventricular drains on our neurosurgical floor. And she developed an amazing, innovative education that I'll let her tell you all about. But again, things that really met our operational need on our unit. And then Megan Giles is the other student that, like I said, had worked with me. And, her program was not a nursing program. It was a master's of healthcare administration. And I had the benefit of having her with me for an entire year, which was amazing because I had been trying to get some support from our Center for Quality and Safety because I knew I needed a project manager. I knew because the project we needed to embark on was going to cross many departments and areas, and it was going to be hard to hold all the pieces together. Megan's program required her to kind of be a project manager to see through a project. And there couldn't have been a better project that just developed at that moment where she could exercise those skills. And so she'll tell you all about that as well. So in the end, these students really acted as innovative educators and project leaders and were a better organization for their efforts. And it was really a privilege to have a part in any of that. So I believe we get to have a little bit of a break, and then you're going to hear from them. Yeah.
So why don't we take 10 minutes and come back at 11:15? And I'll mute for the people online and then unmute when we're back to the break. And then audio back on.
So we're still missing a few folks. So but in my trying to be slightly humorous introduction to. What kind of favor? It's been. Wait, I lost my introduction to.
Oh, someone may have taken it.
It's not up here.
Oh,
Emily,
is it Emily too?
Or I had another one. Red one. There it is. What's it? Oh. Okay.
Just.
A couple people on the front. Okay, so I think we'll call the group back together this morning. And as Eileen mentioned in her talk before break, we are now going to hear from some of our former graduate nursing students, and they're going to speak to us about their evidence-based practice and quality projects. And so first up is Kylie Deppenbaum. And Kylie received her Master of Science in Nursing with a focus in education from Elmhurst University in May. Wow, congratulations. She began her career in 2016 as a bedside nurse at Lurie Children's on the acute care, surgical, and transplant units. In 2021, Kylie advanced in her current role as a nursing professional development associate on the surgical and general medicine units. So congratulations on that and welcome. Kylie, she's going to speak to us about her project implementation of Lippincott solutions to reduce hospital-acquired conditions.
Yeah, kind of touching back on what Eileen went through. I was with a manager on the same unit that Eileen is on the neuroendo unit, and we weren't really sure what my project was going to be. I kind of had an idea and researched something else different for the first half of the year, and then kind of fizzled out. So we went to Eileen and said, like, what can I do? That's actually, we like need it in the institution. And so Lippincott, they had already started working on integrating all of our protocols into Lippincott. And so they were going to launch it this summer and needed help educating all the nurses in how to use it. So I hopped right on that, right up my alley. So just before we get started, I'm just going to say that I have no financial conflict of interest to disclose related to Lippincott. So my global aim for the project is to decrease the rates of hospital-acquired conditions at Lurie Children's Hospital by implementing Lippincott solutions to provide up-to-date evidence-based nursing services. My specific aims related to that were to create an e-learning module and also a tip sheet related to Lippincott solutions to guide nurses in how to use Lippincott and how to navigate the platform to provide evidence-based care. And then once the education rolls out, by the end of it, 100% of Lurie Children's nurses will know how to find their evidence-based protocols on Lippincott because the education module is going to go out to every single nurse in the institution. So hospital-acquired conditions are medical conditions or complications that patients develop during their hospital stay. Lurie Children's tracks the hospital-acquired conditions, also HACs data using different methods. So whether it's days since the last event or just total event count. And then they use those to estimate HAC costs throughout the hospital. So it can be organized by unit, by month, and that's tracked by the clinical quality coordinator nurses on each unit, and then the overall goal of improving HAC costs. So currently, how our protocols work is we use a nursing manual, which has a bunch of PDF documents on it, and the Nursing Protocol and Procedure Committee reviews our protocols every 3 years with content experts to see if there's any update in the evidence-based protocols. And so obviously there's a lag there, right? Not every protocol gets looked at once every 3 years. But future practice now with Lippincott is Lippincott will provide the quarterly updates on their protocols, and then our Lurie Practice Council, Protocol and Procedure Council, now Innovation Board, will look at their updates and notify nurses of any practice changes. So the updates will come quarterly instead of every 3 years, and then the council will disseminate that information so nurses know of practice changes. So the theoretical framework that I used to guide this project was Kurt Lewin's change theory, which has 3 steps to unfreeze current practice, move to the new practice, and then refreeze onto that new practice. So first we needed to unfreeze the current usage of the nursing manual. So I identified driving forces for that, which would be the desire for up-to-date evidence-based protocols, improving patient care and improving patient outcomes, and then also identified restraining forces that might come in the way of unfreezing usage of the current nursing manual, such as just resistance to change, time constraints to learn new things, and just general nurse burnout, which can contribute to those things, not wanting to learn new things, having a hard time integrating new information into practice. So the next step is moving to Lippincott solutions. So in creating that education, the mandatory education module that everyone is going to receive, the tip sheet that kind of will act as a quick guide for nurses to use in the moment at the bedside, and then also doing some rounding to make sure that nurses know where to find their new protocols. And so then in refreezing to Lippincott, we'll totally get rid of the nursing manual as it exists now, and then everything will be moved into Lippincott, and then also reinforcement for nursing leadership to use Lippincott. So what is Lippincott Solutions? So there's a couple of different programs through it. So there's Lippincott Procedures, which is where all of our evidence-based nursing procedures are going to live. There's over 2,000 of them that will standardize care. And as you can see kind of in the picture, there's different disciplines. It's not just nursing. That's just what we're focusing on first, but there's respiratory therapy, physical therapy. And then there's also still down in the corner, Lurie Children's custom procedures, because there are still some of our protocols that can't be integrated into Lippincott. They're so highly specialized to Lurie, so those will still exist there and be able to be used. Next. Then there's Lippincott Advisor, which kind of works like Google. It gives you instant evidence-based clinical decision support. There's patient handouts. There's information on specific treatments and diseases and things like that. There's access to full-length textbooks. So another good resource. And then last, there's OVID, which is a medical research platform that provides access to peer-reviewed journals, textbooks, and full-text databases. So kind of like a search engine to find research for continued evidence-based practice. So then this is the evidence that I found to support evidence-based practice, or EBP. So it standardizes, like I said, practice and improves quality of care and patient outcomes. And then by doing that, reduces the cost of healthcare acquired conditions. One of the interesting studies I found reviewed over 1,000 patient outcomes and showed that 89% of those outcomes had an improvement with evidence-based practice implementation. And all of the evidence-based practice initiatives had a positive return on investment. So it was like only financially beneficial for hospitals to use EBP. And some of this is just showing evidence for implementation of the education module and just using EBP in general. So facilitators for EBP usage is organizational support, which even just being here at Lurie Children's shows the support that Lurie provides to use and implement evidence-based practice. Additionally, Lippincott was chosen by nurses here at Lurie Children's. They reviewed a bunch of different platforms that we could use for our protocols and chose Lippincott. And then also understanding the why for practice change and also having protected time away from the bedside, which Lurie's again also supports because they've provided a lot of bedside time away from the bedside to help integrate our protocols into Lippincott now. And so some barriers that I found to protocol usage is if the protocols are really long, hard to navigate through, unclear language, they were outdated, or even just like lack of knowledge that even that kind of protocol exists, which I feel like Lippincott kind of addresses, and you'll see it on a future slide. But you're able to look at it. There's like a search bar where you can type in exactly what kind of protocol you want to find, or you can look alphabetically, or you can look specifically by specialty. So I feel like Lippincott kind of really honed in on that and makes it easy to find the protocols. And then the benefits of e-learning. So it's easy to use. The education module that I'm putting in place is where all of our education modules exist now. So it's going to be under the same platform and format that all nurses are used to because it's how we do our mandatory education multiple times throughout the year. And so they also saw that e-learning improved confidence and knowledge and improved patient care. And again, it gives the ability to assign it to nurses all over and have it be really easy to use and educate a large number of staff quickly. Some barriers to e-learning that we found were computer access or proficiency, which Lurie's has computers everywhere, all over the units, so that we didn't think that was going to be an issue. And then modules being hard to navigate, which again, it's on the same platform that we already use, so hopefully it should be easy. So an implementation of the education, the benefit of me being an employee here at Lurie's is that the education, we had started to develop it right before I graduated, but actually didn't fully complete developing the module until after I graduated. So as an employee, I was able to like stay on and continue that work and hope we'll see it through to come to fruition this week as it gets assigned to everyone. And then the tip sheet I created, which I'll show you in a moment. And then they're still working on integrating our protocols into Lippincott. So that's ongoing work as well. So this is what the tip sheet looks like. If it's printed double-sided, it's just a page and a half, right? So just like a quick resource for nurses in the moment when they're trying to find their protocols to be able to look at this and know how to find them. Like I said, it kind of hard to see, but you can search alphabetically, you can search in the search bar, and then actually how to navigate once you open a protocol, like what that looks like. So it makes it really easy. There's like a skills checklist or quick list, so you don't have to read this long protocol. You just need like the down and dirty of I need to do this and then this and then this. There's a way to just click that and have the quick down and dirty list. And then there's also like a section that allows us to add specific things for Lurie nursing, right? Because we have a lot of special like CCGs or other tip sheets related to that. So there's a nice spot for us to be able to integrate our information into Lippincott as well. And then just another sheet for advisors. There's like a quick in the moment thing for nurses to use. If you go to the next slide. This is what the education module is going to look like. It's 5 minutes, so not super long, right? Quick, holds everyone's attention, hopefully. It's a voiceover screen recording of me actually navigating through Lippincott, so you're seeing it in real time as I'm talking about it. Not just like pictures of it, but actually navigating through the website. What happens when I push this button, or how do I search for this protocol? And then there's, I think, 3 questions at the end that just test their knowledge, and they have to answer all of this correct to finish the module. So. And finally, outcomes. So the monitoring of hack rates will continue to be done by the clinical quality coordinator nurses on each unit. So hopefully we'll see an improvement in some of those. Like I said, the quarterly updates on the evidence-based protocols will come from Lippincott, and then that actually gets disseminated on the Lippincott platform. There's an announcement section, so you'll be able to see what protocols are updated. And then, like I said, they'll also continue to review those highly specialized protocols every 3 years. And then take one more question slide.
Great.
Thanks, Kylie.
Yeah.
As a speaker, don't you love when there's no question?
Yeah, must have just been so thorough.
Strong work. Okay, well, now it is my pleasure to introduce Melanie Balanon. Is that correct? Yes, okay. Melanie is a registered nurse on the resource team at Lurie Children's Hospital, where she has provided care across a variety of pediatric units for 6 years. She earned her Master of Science in Nursing with a concentration in nursing education, also from Elmhurst University in May 2025. Congratulations. She completed her clinical practicum under the guidance of Michael Olson, Lurie Children's Clinical Quality Coordinator for Neurology, Neurosurgery, and Endocrinology. Michael, that sounds like a big job. As part of her capstone project, Melanie developed an innovative educational escape room focused on the management of extraventricular devices, or EVDs. This initiative was created in response to a rise in safety events involving EVDs aimed to enhance nursing competency and patient safety through immersive scenario-based learning. So please help me welcome Melanie.
I am Melanie. So my presentation is on enhancing nursing education through an EVD escape room. So my global aim is to improve nursing education on EVDs at Lurie Children's Hospital, specifically the neurosurgical unit, through an educational escape room focused on the nursing management of EVDs. The goal is to enhance nursing skills, reduce safety events related to EVDs, and improve quality of patient care. And this addresses a recent increase in safety events on the unit. For my specific aims, my first aim was to implement this escape room in the annual education days for 100% of the unit's nurses. To evaluate this, I created a post-activity survey, including an escape room perception scale, as well as an end-of-day evaluation, which is kind of the focus of aim 2. So 95% of participants will be able to describe EVD nursing management. And the question is, after attending the skills workshop, I will be able to describe the nursing management of a patient with an EVD. Also measuring with like a post-activity debrief right after the activity. So our identified problem, while I was working with Michael, we noticed an increase in safety events reported regarding EVDs on the unit over a 2-month period. So I have actually had a different project that I was already working on, and we kind of pivoted to this to address a more urgent concern. And some of these common issues that were included in the SIRS or the safety events reported were missed safety checks, confusion with EVD orders, or inappropriate or missing EVD supplies. So this highlighted an urgent need for re-education and training. A lot of these nurses have been here for a while. They are very knowledgeable in their skills, but maybe need a little bit of a refresher. Some of the newer nurses also know the skills, but maybe need a confidence boost on escalation of concerns, or who they can go to ask questions. This is the essay cycle that I use to guide this project. I won't go into too much depth because I'll talk about it throughout. But the education committee actually approached me and asked me to create this education or this escape room for their education days. So I thought it would be a great opportunity to create something fun and engaging rather than another like simulation. They do a lot of simulations, so I wanted to think of something a little bit different. I engaged with multiple stakeholders, researched the best evidence, and created these evaluation tools. And yeah, I'll speak more on this throughout. And I used Lewin's planned change theory to guide this project as well, which Kylie kind of touched on with the unfreezing, moving, and refreezing. But one thing I wanted to highlight was the emotional aspects of change. All parties that are involved in change must be accepting of it and understand the gradual process. However, it is an emotional process, therefore it may be complicated and difficult. So when creating this escape room, I didn't expect there to be such strong opinions on how it should be, but it does make sense. These nurses are very passionate and protective over their unit. And so I wanted to honor that as much as possible by engaging with them throughout the project, as well as engaging with the neurosurgical department, the doctors and the PAs and the NPs, as well as Michael, my preceptor, the educator as well, to kind of have these ongoing conversations on what these nurses actually need. Slide, please. This is just a brief overview of the supporting evidence that I used. The first four essentially just show how beneficial escape rooms can be as an educational tool. And the last two I really want to focus on by Morel and gLocal. They created a cardiovascular escape room for Gen Z nursing students, and they found statistically significant knowledge improvements. And what I was really impressed with was the last article, in which participants reported enhanced soft skills such as communication, collaboration, confidence, and critical thinking. And so originally I was going to do like a pre and post knowledge survey, but I was also talking with the education committee and the nurses, and that was not something that they felt like they needed or wanted. So I really wanted to focus on these soft skills so that they felt confident and comfortable asking the questions, looking for answers, escalating their concerns through the chain of command through the doctors. And I think this also ties into our HRO principles as a high reliability organization where we have enough systems in place to catch these small deviations. So I think of like the Swiss cheese model, all it takes is one person first to speak up for safety to prevent a potentially fatal error. And so that's what I wanted to focus on. We have, with all that being said, this is the overview of the escape room. It was 60 minutes, so that includes 35 minutes for the actual escape room. Participants were in groups of about like 5 to 7. They had 3 hints. There were 5 lock boxes. And then all of the groups, I think there were about 6 or 7 days, they all completed it within the 35 minutes. And then they did a 25-minute debrief. So that was led by the facilitators from the education committee, about like 1 to 2 people each time. And then they also completed the post-activity survey, which I'll talk about, and then the end of day evaluation for their entire education day for their CEs.
Just for the international audience that may view this later, can you define what an escape room
Oh,
is?
yeah. So it's kind of, it isn't a room where you're essentially locked in, not really, but it's like a game where you have to complete puzzles in order to escape the room. So here the learning goals and objectives are a good example. In order to escape the room, they had to unlock each box in order. So for example, they had to verify their safety checks or verify orders and complete their safety checks in order to find the numbers to unlock the first box. The second objective, they had to independently decide to do a neurological assessment. And when they did that, they would pick up the pen light to check the pupils, and that had a QR code for a cipher. And the cipher was them determining what the appropriate vital signs would be if the patient was experiencing increased intracranial pressure or signs of Cushing's triad. And so once they completed that code, that opened the lock to the next box. For CSF specimen collection, they needed to correctly label the specimens in order, and each label had numbers, which also then opened the next lock. And for ICP monitoring and chain of command, they needed to properly set up the ICP monitoring before being able to open the last clue. And that one was kind of just the facilitator watching to make sure. And it had like, it was like a fun little cipher. Well, I think it was fun. Maybe a little stressed. And if you go to the next slide, all these puzzles led up to the finale, which is a video from Dr. Raskin from the neurosurgical department. And it would play.
It might play, but it might not record online, but I'll play it for them.
Congratulations, you successfully shared your seven and escaped LC-19. Thank you for escalating your concerns to me. Let's go ahead and level the ED at 10. Thank you for all that you do.
So all of these puzzles led up to this. The patient in the scenario was experiencing signs of increased ICP, so the nurses had to then care for that patient and figure out a way to escalate their concerns. They had to figure out where they could look for their resources, such as setting up the ICP monitoring. There were different things that they had available to them, like their resource finder. They had their own units like Instagram. But I really love this video because it highlights the multidisciplinary collaboration that was done throughout this process. Multiple stakeholders, not just nurses, but throughout the departments. And I also created this escape room facilitator guide because I wanted this to be sustainable for not just my project. I also was not able to attend every single session, so there were members of the education committee who had to do this in my absence. And here, I know it's kind of small and I forgot to bring the actual binder, but it shows facilitators how to run the escape room, how to set it up, what materials they'll need. There's pictures on what everything should look like. QR codes, the QR codes for the participants, but then QR codes for the facilitators so that they could see the answers or edit the surveys if they need to. And this is also all in a Dropbox. So then this is the post-activity survey that I used. This was adapted from those articles that I mentioned before, specifically from Morel and gLocal. And this is the escape room perception survey. I wanted to better understand if the nurses actually liked this gamified education and if they felt like they benefited from it. Overall, the results were majority positive. Most nurses would recommend this activity and felt that it was an effective educational tool for them. I know it's kind of small here, but the questions were, they would rank strongly, disagree, disagree, neutral, agree, and strongly agree. And the first one says, the escape room encouraged me to think about material in a new way. And most participants agreed or strongly agreed. Next one is, I would recommend this activity to other nurses. Again, agree or strongly disagree were the responses. Next was, I learned from my peers during the EVD escape room. Again, positive results. The escape room was an effective way to review EVD nursing management. Again, positive results. And then here, I think I might have messed up where it was strongly disagree, and people might have just clicked all agree or strongly agree. But it says it was difficult for me to focus on learning because I was feeling stressed or overwhelmed. Most people felt like it was not that difficult. And the next one says the non-educational portions, such as the lockboxes, puzzles, distracted me from learning about EVD nursing management. Most of them did not think that. And then the last one says, in general, I enjoy playing games such as like video games, board games, social media games, etc. So this one was mainly just for me to see if they had fun, if they liked it, if they wanted to do something more in the future. I also included open-ended questions. So I asked, and this was all in the Microsoft Forms, but I asked, what did you like about the escape room? So participants appreciated how it was interactive, fun, and creative. And then I also asked, what would you change about the escape room? So locks was a big one, but I think that's because I could have spent more time in the pre-brief talking about how to use the locks. There were a lot of questions on how to physically open the locks. A lot of them were numbers, some of them were letters. One was a directional lock, which I had actually never used before either. So maybe I could spend more time in the pre-brief in the future going over that. I did have instructions on the locks underneath the lock, but somehow people still missed that. So just something to consider in the future. Then I also asked, what is one takeaway that you will bring back to the bedside? And when observing different groups, I found that most of them actually spent the most time on the first box, which was the safety checks. So I'm pleased to see that safety checks is something that they will continue to do or take away because it's kind of sets the foundation for how you'll be caring for the patient for the rest of your shift. And where a lot of our safety events had stemmed from as well, or could have been prevented. And lastly, is there anything else you'd like to add? Any other topics that they would like to see? I think it's interesting that most participants mentioned halo gravity traction because that was my initial project before we pivoted to EVDs. But hopefully in the future with my facilitator guide, this could be implemented for that and other diagnoses, as well as other departments. And this was the end of day evaluation. So this was for their entire education day. They filled out questions for each of their skills workshops. And so as a reminder, our goal was to have 95% participants either agree or strongly agree. And as you can see, I think there's 20% that agree and 8% strongly agree. So that's a total of 100%, which exceeds our initial goal. So to briefly touch on the financial impact, it's a lot of words and numbers, but it's just me showing my work. Potential EVD complications include infections, occlusions, and prolonged stays. On average, it costs about over $67,000 more to care for a patient with an infected EVD. It's unclear how many of these patients that were in the safety events reported developed an infection, if any. But if this education can prevent at least one infected EVD, we would have a 1,148.65% return on investment. Challenges and considerations, I kind of touched on this already, but we also found out that the ICP protocol was outdated and the pictures included old supplies. So that was kind of an incidental finding, and we're now in the process of updating that to make sure that it's up to date. And then to allow time for the adequate debrief, we actually shortened the escape room from 60 minutes to 35 minutes, which meant we did have to cut out some of the clinical skills, such as collecting the EVD specimens or changing the bag, which is what some participants said they wanted to see. But now that we know that this is beneficial in kind of a smaller sense, we could make it longer if that's something they would like. But I think overall, many of these bullet points can be addressed with overall improved communication in the future, such as explaining the locks more in depth during the pre-brief, but also emphasizing to them that this is a fun educational tool rather than a clinical simulation that will be reported back. And I kind of tried to do that with taking away the pre-test and the post-test, but maybe could have highlighted that more. And for practice implications, overall gamified education, specifically escape rooms, are an effective strategy to reinforce clinical skills and engage staff. I mentioned many of these points already, but I really wanted to highlight the last bullet point. This project supports a shift towards evidence-based interactive learning in clinical education. And for continuous improvement, there's always room for that. So we must emphasize ongoing education and reinforcement of EVD nursing management practices through a safe learning environment. We may also explore opportunities to extend this to other departments who care for patients with EVDs. There's already been interest in educators and clinical quality coordinators from those units, and some of them shadowed the education or the escape room. Even educators and CQCs from other units who don't care for this patient population wanted to come and shadow because they wanted to explore this concept for their own patient populations. Like I mentioned, halo gravity traction. We could use this for diabetes, tracheostomies, more. Yeah. These are my references. And then the last slide. Any questions?
Beginning, you talked about how an increase in EVD related safety events kind of prompted the project. We're able to look at the post-education time to see if you had less EVD related safety events, because you could also add that to proof of
Oh, yes. So when I presented and compiled all of this, it was the last education day was 2 days before I did my final presentation. So there wasn't a lot of time to actually look at that data yet, but yeah, 2 days. See, hopefully none of those 2 days, but yeah. I guess we'll see. I still work here and I still work closely with Michael, so we can always look at that too. Because this is definitely something that I would want to bring back to my own unit as well, if it is beneficial, which I think it is.
If you're looking at discrimination, which I think you should, you can.
I was about to say, the numbers of safety events have significantly decreased since this happened. And I'm sure you're curious from a magnet lens. So.
Yeah.
3 data points. 3 data points.
I just wanted to comment that one of your bullet points about maybe some feedback, it was one of the last ones that said, oh, there was a risk of people sharing information, you know, for a later one. And I was like, great if that happened.
Yeah. It was kind of cute that they got very like competitive and they wanted to like beat each other's time. And so again, just a different way to think about things rather than like simulations are great, but it's also not the only tool we have. And just another tool in the toolbox for us to use.
Fostering a team environment, that's really cool.
Yeah, I really loved the soft skills that they talked about. And that's when it kind of all clicked for me where I'm like, okay, this would be great for the escape room itself, because there's so many ways that we can increase knowledge or measure knowledge, but this is something that you kind of, soft skills are something you can't really teach. You have to just practice, and that's a lot in simulations and escape rooms as well. Thank you.
I always want to know if somebody's still stuck in the room. Does anybody get stuck? Yeah, room's out. Okay, so our last speaker, before another break, is Megan Giles. Megan has 4 years of experience in the healthcare field. She recently graduated from the University of Illinois at Chicago with a master's degree in healthcare administration. During the second year of the graduate program, Megan spent time at Lurie Children's Hospital working on various process improvement projects throughout the hospital, and she's going to come and present to us.
My name is Megan, and during my second year here, or during my second year of my graduate program, I really heavily focused on violent restraints, looking at those processes and how can we improve, because it's so heavily tied with our CMS and regulations. So this slide is really just a project target. I'm not going to run through it. We'll run through it kind of throughout the presentation, but I really just want to highlight that there's been many previous iterations of improving violent restraints, but those have kind of led to the success of this project. It is also very heavily multidisciplinary. So we have a heavy project team consisting of our accreditation readiness, we have our education, we have our physicians and providers, and also our nurses. So it really affected everyone and really took a big team to really make this project really successful. So going into kind of the project goals and what this was about. So to ensure our safety and organizational compliance regulations, our team really aimed to make compliance with CMS regulations as well as our Lurie Children's policy easier, complete, and consistently excellent by improving processes, improving those audits and feedbacks, developing new tools, and also raising awareness. So this really dove into how can we develop improved provider and nursing workflows for our patients that are experiencing those violent restraints. How can we monitor in the documentation? How can we improve the documentation and make sure that we are hitting all of those regulation points? How can we implement new tools within our technology system to help along with that? And then also, as always, making sure that there's an education campaign that's really hitting all of those different service areas. So as I said prior, we're really hitting all those nurses on different department floors, all of our providers, because it really takes the whole entire team to make this successful. So a couple project aims and metrics. So we had one outcome metric that was really looking at the rate of compliance that was required from those restraint audit elements. We had 3 processes, so we're looking at those tools developed and implemented, those processes, and then also the education, as I said prior. And then we also have this balancing metric that is really focusing on our patient and staff safety. So kind of looking into it, prior to starting, we really wanted to do the current state analysis. So we conducted and validated various assessment with those frontline staff. We went to our providers, we went to our nursing, went to all of our frontline staff and kind of asked, what are those barriers and why are we not hitting 100% on our compliance rate? So this really addressed these challenges with this low frequency and high stress event. So a couple of the takeaways, we really understood that they were struggling with finding those resources to begin with. So when violent restraint occurs, where do they find those resources to even know what to do? So we've got that one. And then also our behavioral response team involvement. So there has been many times that this BRT team has not been involved within the violent restraint. So we really wanted to hone in using that team to really be there at every restraint event, and then that would have a greater alignment with all of our clinical needs. So we have our fishbone diagram, and this really drove to our recommendations and implementations at the end. So while still doing this current state analysis, we saw some major themes, and I just really wanted to look into what are some of the best practices when a patient is placed into violent restraints, and how can we assure that safety as well as this organizational and documentation compliance needs. So I looked into this sepsis huddle. So we've learned from our own organization that we do a huddle and there has been great success. So I looked into that a little furthermore, and it really led to having a higher completion rate of required elements, which was very crucial for both sepsis huddle, for sepsis as well as violent restraints in regards to those regulations needed. I also looked into the compliance with best practices, so implementing best available evidence in the use of physical restraints. So this really led to seeing that there's a decrease in restraints post-intervention, as well as highlighted the sustainability was really going to need that ongoing continuous staff education, that monitoring, and also that leadership support to make sure that it's continuing and building off those improvements that we've seen. And lastly, I researched other hospitals that were very similar to us. So our Cincinnati Children's Hospital, so they did a similar project that was really improving restraining safety through improved EMR documentation. So from that, I saw a couple of themes that they really had their BPAs, their pages that were an effective tool. They created metrics that captured compliance rate, that easily visualized who were in restraint and what was needed to happen and where are we at in the processes. As well as they revised their flow sheets and POC that serves as their checklist as well. So they kind of had they did the processes, but then they also had a back-end checklist to make sure everything was going appropriately. And this really ensured that this documentation was completed correctly and also timely, because time matters within this whole project as well. So after we looked at those, the research, and also we met with our frontline staff, I was able to really identify 3 strong themes that we really need to work into. So we had 3 small working groups. We had our huddle and documentation team, we had our technology team, and also our education team. So these were 3 diverse working groups, really ensuring representation of impacted stakeholders, and it really grew on the success of the other small previous iterations. And then also, this was an expert-driven working group. So each group included the right experts to ensure efficient problem solving, and also the groups focus on specific tasks within a defined timeline. So, which these were all really gathered from our key driver diagram to really see what were those barriers that were really urgent and priority that could be helpful. And then we kind of divided them into the 3 buckets as well. So, onto the fun recommendations and kind of what our team really led to were, so the first one, our huddle and documentation team, they really looked into having this restraint huddle stat as well as a checklist. So our current process, the patient exhibits behavior, our BRT stat should be initiated, and then if less restrictive interventions failed, then our patient is restrained. Now, that was our current process. From this group, we really added into, after that patient is restrained and is safe, we will initiate a violent restraint huddle stat. And this team included everyone from the BRT stat, but it also included our ordering provider. And this ordering provider is going to be this huddle leader. And this huddle leader is really responsible for making sure all of the key players are within this huddle, as well as going through the checklist that we have printed, laminated, and right there in front of them when this happens. So this violent restraint huddle stat checklist is going to have a bunch of bullet points that really go through what are those key elements that CMS is looking for, what is our policy looking for, and making sure that we hit every single one so then we can overall get to 100% compliance rate, which is crucial. So that was their big intervention. Moving on to our technology team, and they did a lot of new and updated technology tools within Epic and Power BI and whatnot. So we looked into updating the order. So we heard that there was issues with renewing the order and they didn't know how to do it. So we put the two orders, our violent restraint and our non-violent restraint, into one order, and we just added more of a keyword that is it initial, is it a renewal, is it a violent, is it non-violent. This really ensured that we can put a time on those orders, because orders are time-based. So based off your age, you get 1 hour, 2 hour, and every certain hour you have to either renew them or you have to discontinue them. And that's very prominent within the CMS regulations in our policy as well. So this really helped have those clear end times and a countdown to expiration. Next, we built a restraint toolkit. So we've seen from other people within the organization, they have built other toolkits, and we really built on that. So this will live within our behavioral health navigator, and which houses all of our relative resources to assist with restraints along with the documentation. So I'll have the documentation in there. It has our SharePoint site in there. It has all those documentation guides. So it's kind of a one-stop shop, really. Like the first thing that they can do, they can go there. We also like that current state analysis, we talked on that leadership support, and within our research, leadership support is really a big deal. So we added automated leadership alerts. So these were alerted when a violent restraint episode was initiated. This is going to be the directors, the managers on the floor, and whoever else feels that they should be alerted every single time that a violent restraint is initiated, so they can monitor and make sure that those elements were completed timely order. Another one was our storyboard alert. So on the left-hand side within Epic, we have our storyboard, and there'll be a section with alert that says if it's yellow, it's your order is nearing expiration. Please order the next one soon when it's expired. Or we'll have a red tag that says the order is expired. It needs to be either renewed or it needs to be discontinued ASAP. We also have a provider note revision, so we added smart text for all the vet notes, and so I've really just made it more simplified for them to make sure this documentation was appropriate. And then lastly, they added a column within our patient list, so for our frontline providers, that really identifies which patients are currently in restraints, and so just everyone is aware on that floor, or if it's within their patient list, they're aware of it, and they need to make sure that those elements are completed and whatnot. Since all of these are really big improvements, we really needed to educate all of our staff members so then this can appropriately happen every single time. So we first revamped our SharePoint site. So we've made our non-violent versus our violent restraints. We have all those documentation guides. We have all those resources. We have the policy within there, and just anything and everything that someone might need if they don't know how to do the violent restraint procedures, because violent restraints is a low frequency event. And so we're not asking people to know every single time, but they need to know where to go in order to know what to happen. So with that, we also updated the restraint binders in each unit. So when I walked around, there was multiple units that maybe didn't have a binder, or they had multiple variations of binders. So we really took all of those binders and we made one binder that we put it into each unit, so everyone has the same information. It's all updated and whatnot. We updated the documentation guides for both nursing and our providers. So with all of our new Epic tools or our implementation of that huddle and checklist, we really wrote out kind of what they need to be doing, what they need to be documenting, because we really heard that within our VAERS assessment that they didn't really know what to document per se. So this was a great tool that they can just have it right in front of them and they will know exactly what to do. We also created consistent educational content for both our nursing providers. So we went to many different meetings to make sure that we captured all of the disciplines that were going to be affected by this new processes. So that was extensive, but we hit a lot of them. And then lastly, as I kind of touched within the research, that we were really focused on that sustainability. So we needed to implement a continuous education. So we've implemented Workday as well as our resident education. We paired with our accreditation readiness team that were able to educate the new residents and within their rotations.
Do you want me to play this?
It doesn't play, it won't play, but we have the photos and we did a video and whatnot. And those are just our different ways on how we disseminated the education. So there was a phase 2 just due to a scope creep and how extensive this project was. So within this phase 2, we really found that we do need to focus on a couple of different areas in order to hit and make sure that this process was successful. So next slide, please. Within our phase 2, we focused on 3 different things. Our first one was the addition of another work group. So now we have 4 work groups, and this was our audit process. So this was a small work group with some of our managers on each floor because we have transitioned the audit process to be focused and completed by the managers on the floor. And this was currently, or previously, this was the charge nurse role, but now this is the manager role. So we had a transition from RedCap to AMP Tracer, and then we have transitioned the time from having the audit done within 24 hours to within 7-day mark. And so we were really able to use their frontline guidance and those barriers to really identify the correct process that was needed. Secondly, we had ongoing oversight. So we had a Power BI expansion. We already previously had a Power BI from our other previous iterations, but it only really focused on the 4 elements, I believe, of the CMS regulations. And there's actually, I think, about 12 that needs to be hit in order to hit 100%. So we are identifying kind of how we need to expand that. How do we get all of those elements in there so we can easily identify, are we 100%? What do we need to do? And then also, as I said previously, this leadership oversight plan. So if there's an issue happening with our restraints and we're not hitting that documentation compliance rate, who is it going up to? How are we going to address this? And that's really just a partnership with our accreditation readiness team, our unit leadership, our behavioral health oversight committee, as well as our healthcare delivery council, in order to make sure nothing falls through the cracks and we address what needs to be happening. And then lastly, as you saw all of our great iterations and what we're trying to really do, there was needed to have a policy revisions. And this was just updating all of our algorithms since we added new tools and new links and new the huddle. Like we needed to update all those algorithms that mentions from our violent restraints. So we went through our violent restraints, we went through just our even our non-violent, to link all of that and make sure that the tools are all readily available for whoever comes across a violent restraint patient and needs a little additional help as well. And that was the violent restraints.
We have a little break in the schedule next, so you want to take 10 minutes, 5 minutes? What do we think?
Yeah.
It's good. 10 minutes? Okay. Come back at 12:15 and we say okay.
I just reached out. So
All right, so let's we're back together in the spirit of staying on time, which we've done well so far this morning and this early afternoon. So now it's my pleasure to introduce you to Kate Gordon. And she's currently a student registered nurse anesthetist at Rush University. Prior to this program, she studied nursing at the University of Virginia and worked in the medical ICU at VCU Health in Richmond, Virginia. Like many nursing staff at Lurie, Kate cares deeply for vulnerable children across the care continuum. She looks forward to joining the anesthesia team at Lurie Children's as a certified registered nurse anesthetist upon graduation. And she's going to speak with us about her project from vulnerable to visible CRNA education on child trafficking and exploitation. Welcome, Kate.
A certified registered nurse anesthetist, CRNA from here on out. You did a lovely job clarifying that for us. Thank you.
But good for you.
My name is Kate Gordon, and my project is titled From Vulnerable to Visible, Improving CRNA Awareness of Child Trafficking. This is the beginning of a systematic and sustainable effort to improve the detection of child trafficking and the care for vulnerable children. I completed this quality improvement initiative here at Lurie, as you mentioned, during my DMP project, which is part of my nurse anesthesia training. So we're going to spend some time talking about the prevalence of child trafficking, risk factors, and why we need to be vigilant as healthcare providers. And then I will take a step back and I'll lay out how I structured my QX project to address the gap that I identified. So this is the culmination of my DNP project in poster form. And what I did was I was able to reach a group of CRNAs and educate them on child trafficking detection in the perioperative space. And then I collected feedback from them on the quality of that education, refined it, and was able to share that at Lurie Grand Rounds with a group of advanced practice providers. And right now we're going to zoom in on this education piece. And I'm going to give you a couple of slides of just a highlight of what I shared with them, just because I feel like the more years that this falls on, the better as far as helping our vulnerable children. So we started training with this goal. I wanted the audience to leave with an understanding of how child trafficking presents in the surgical setting, and then how to equip CRNAs to recognize and respond to suspicions. Some time establishing relevance, because you might be sitting there thinking like, how, like, we've heard that the ED needs to recognize them, we've seen signs in airport bathrooms, but how is this relevant in a surgical setting? That was a common trend. So we spent some time establishing relevance. And one of the key statistics here is that up to 88% of victims of trafficking of a study of primarily women and children sought medical care during their time of trafficking and exploitation, and very few were identified by the healthcare system. So kind of a staggering statistic there. And my literature review revealed that victims of labor and sex trafficking do present for surgery. As you can imagine, there might be gynecological intervention for victims of sex trafficking, and then there might be orthopedic intervention for different falls, breaks, fractures sustained from abuse or other work-related injuries. Next slide. So after establishing relevance, we moved on to, I also want to mention that the literature says 1 in 4 victims of trafficking are reported to be children. So that's why this had relevance at a children's hospital. And really, this is everybody's responsibility. It's educational efforts are often directed at the emergency department, and that's great, but kind of the more we know about this, the more we can intervene. So after establishing all of that, we reviewed definitions of trafficking. The media has brought a lot of attention to sex trafficking, but labor trafficking often gets left out of the discussion. So spend some time parsing out those two. And then next slide, please. We talked about the overlap between abuse and neglect and trafficking. In minors less than 18, all trafficking and exploitation falls under abuse. It's a little bit different when they're over 18. That gets a little bit hazier. And then smuggling involves the crossing of borders, which people often confuse with trafficking. And then again, we use data to reinforce the problem kind of in our own backyard. The top numbers are some national trends for trafficking, and then the bottom numbers are Illinois and Chicago specific. So just to show everyone that this is a problem in our own backyard. Next slide, please. I tried to intersperse a game of fact or fiction to keep the audience engaged. and aid in learning and retention. So I would ask questions like most traffickers seek out children who have run away from their home that they do not already know. And then the participants just answered in their head, and then we'd go on to the next slide. And this is technically a fiction or false statement because most traffickers do, while runaways are high risk of trafficking, they usually have a relationship already with that child in some form. Then we spent some time talking about populations at risk. So children who are runaways or homeless, past abuse or trauma victims, kids in the juvenile correction system or foster care, and then non-conforming gender groups. And we talked about common presentation. So we already mentioned orthopedics, trauma, burns. And then a lot of these cases have delayed presentation. So the dental pathology. And then after that, we talked about ways to identify victims of trafficking and red flags to look for. This is really difficult. Sometimes there's no signs, sometimes there are signs. And a common thread in the literature is the tattoo that I'll mention, money signs, or a name kind of demonstrating ownership. And then their history can shed a lot of light. And then anytime they're with a guardian that things don't feel right, they're a non-family guardian who's dominating or controlling the conversation. And then lastly, some next steps at Lurie and some local resources to how to escalate concerns. And the big picture for them was to get social work involved early if you have any concerns. And then Lurie has some systems in place to move forward. And the National Trafficking Hotline is always a great resource. So now, kind of taking a step back and talking about the project implementation and how I structured that. The general strategy of this initiative was a pre and post test and original design, and I followed a plan, do, study, act model. So first thing I did was evaluate the existing educational offerings. And Lurie does have learning modules on abuse, and most hospitals have trainings on abuse, and it'll be like a slide for trafficking. So that was a gap identified. And then I presented at the CRNA staff meeting. It's about 30 minutes. That presentation that included some case studies, a presentation, and then a video from a survivor of child trafficking to include the survivor's voice. And then I collected feedback from them in person on the quality of that education. I revised my education and I shared that with a group of APPs at grant rounds with another Lurie nurse practitioner who was alongside of me. And then 3 months later, I did a post test to assess for retention and see what they remembered. As far as results, so you can see a significant portion of the CRNAs were captured in the audience. Fewer APPs, it was about 40 of the total 400 that were attending grand rounds. And my assessment data at the 3-month mark showed a very modest increase in scores. I think it was about 12% increase, and their average score on that test was 57%, and I wanted it to be greater than 80. I wanted them to have more than 80% accurate answers. And despite the positive feedback from the CRNAs, I'm like, oh, this training is great. This is interesting. This is what was valuable. It didn't translate to increased knowledge and retention. And there's a couple things I would do differently. Thank you. The first is I would do an immediate post test so I could assess the quality of my education then, like were they ever going to rise in their scores and immediately after? And then I could have looked at it again 3 months later of, okay, you performed well here. Can you remember that content 3 months later? That would be one change. And then although I tried my best to make the presentation interesting and engaging, like I think it was Melanie, like the use of gamification might be what takes things to the next level here. If I had them answer questions in their head, so I didn't know what they were thinking and if they were reaching the right conclusion. But if I had used something like Poll Everywhere or Kahoot, I could have been like, oh, a lot of you think this, which is a common misconception because of something you've seen on television. And then we could have redirected and provided education to address those misconceptions. And the in-person training did facilitate feedback and participation.
And then the participants reinforce the value of including the survivor's voice. So it's like a 3 to 5 minute video from an individual that was a victim of child trafficking, and they shared their story. So naturally, that was really interesting and engaging and meaningful to the people listening. So again, here's my project. Okay, one more slide. We go back. So the next step for this project, as much as I want to just drop a screening tool in and say, like, go identify people who you're concerned about, the education and the policy development really has to precede those interventions. So that's what we're focusing on, is the education. And since then, we didn't want it to be a one-time intervention. I was able to present with the CRNA, provides it to the advanced practice providers. Now I'm here, and then I get to share this content again at a national conference in August. So expanding that way. And then thinking through the best way to maintain this education as like a more enduring learning content, because education and policy development, has to precede the screening tools that are ultimately going to help us flag social work sooner and help get the resources and support structures in place that's needed for these children. So lots of work to do. And then a point of self-reflection, and the question I want to leave you with, especially if you're in a patient-facing role, is, are you moving at a pace in your day-to-day operations where you would notice if a victim of trafficking was sitting right in front of you? Next couple of slides are just some extra resources, like a decision algorithm, and then identification resources. There's some more. And then this is the only validated screening tool that I'm aware of that they started to trial in some pediatric emergency departments.
This is fascinating. Any plans to publish this project?
Yes.
So I want to ask that question of all the speakers who presented the project, because I think all of them were outstanding and certainly worthy of publication. And I think that although we may think we don't have anything new to say, I think all of you do have important things to say to others and healthcare. And I think even if it isn't, maybe you think it's not new information, it may be new information to folks in your field. So, focusing on a journal within pediatrics, within the CRNA community, whatever it may be new. The whole idea of the gamification and using escape rooms was fascinating. So all of these projects have just enthralled me, and I just would love to see you all publish them, certainly.
Thank you for that encouragement.
Yeah. And Kate was able to hand her project down to a student in the class behind her as well. And that student is developing a tool to evaluate institutional policies based on the HEAL protocol, so that institutions can look and see if their policy aligns with best practices for detection and response. And like she had said, education, policy, and then action. So that's sort of the plan. And then the nice thing is that Kate can mentor her, and that starts creating some of that synergy between people to work on projects and to share authorship and support and things like that for publication, for dissemination, and so on. Maybe we can run the chairs and to the other side.
Okay. So our last presentation, give us, a little grace while we move about, but we are going to have a panel of mentors who have mentored project DNP and master's level project and PhD projects at Lurie Children's and share their perspectives in a panel form. Michelle High, who is a PhD candidate at Rush University. Sadly, I don't have your bio. But Michelle is one of our co-chairs of our new innovations board. And our panelists include Audrey Rosenblatt, who you met, Eileen Romano, who you've met, Michael Olson, who is the clinical coordinator, quality coordinator for the neurology, neurosurgery, endocrinology, and orthopedic surgery units at Lurie. He received his Master's of Science in 2010 at DePaul and has worked at Lurie Children's for over 15 years. The majority of Olson's work focuses on quality improvement initiatives and safety science, both on both unit and hospital-wide levels. And I am a nurse scientist and developmental specialist in the neonatal unit at Lurie. And so I will also be serving on the panel, but I left my notes. So. Thank you.
I can open it up with an initial question and then we can, if then we can open up to everyone else for a few other questions. The first question is, can you share a particularly challenging or rewarding experience you've had while mentoring a student through a scholarly or quality improvement project, what you learned from it?
Everyone, please speak up. Yeah, we're sitting further away from the owl, so we have to.
Yeah.
Project it. If the eyes don't line up with the two owls, then it will stop recording, so. We're so close.
I can start. Thinking of a particularly challenging situation. I've had the opportunity to precept 4 separate Elmhurst nursing students at the hospital, and the first time I precepted this was in the fall of 2019. I worked with Kelsey Van Dersen. She was a nurse on the 20th floor, who no longer works at the organization, but we partnered with Eileen to implement the IPASS family rounding process, specifically with the epilepsy services on the 19th floor. And then in March of 2020, I think something happened in the world, which caused some deviation in the project. And I think that was, which really kind of mirrored their experience, but then also delayed the rolling out of this project. But however, that work has continued throughout the hospital. Special recognition to the 21st floor, who has really done a phenomenal job with implementing patient family-centered rounds. So that was definitely a challenging opportunity, but with a good ending.
I think I've had both positive and challenging situations. I think that there's good and bad with every project. There's always a little bit of a struggle. I would say that I've worked with DMP students from Rush and from other places. I'm on 3 dissertation committees right now for some PhD students, and I'm also doing some, I've also done Elmhurst students. So I think with each one, some of the challenge for me is when you're on various student projects is keeping track of of the time frames for them. I'm always like, remind me where we are in what semester, because some projects are a semester long and some projects are a year long. And what are we doing this quarter for your project over in implementation? Okay, like help me reframe as in regular meetings with students so that you know that they're continuing to work. So that's been a challenge. I also think the end of the project is a challenge because I'm not done. I want to work on dissemination with students, and I think some of the programs are set up, and it's good to know this going in, and I'm getting better as I've done more. Where does this project fall in their overall schooling? Because if you're doing your DMP and then you're going to do all your clinical hours, become a nurse practitioner or CRNA, you may not have dissemination on your mind. You may be like, I'm moving on, I'm doing my clinical practicum, and then I'm getting a job somewhere else soon, and I'm not going to be available to disseminate with you this work. And I think as a mentor, what's challenging to me is you often put a lot of time and effort and care and concern over it, especially if it's a project that we've taken the time to say meets a need clinically. And so we want to disseminate it in the organization, but beyond the organization. And so now I didn't make this up, I learned it from another organization. I now say to students, if you are not invested in publishing this work within like 6 months of completing this, or we're not in discussion about that, I will publish this as your mentor. Like, and I don't know where we land as an organization on that, but I feel like we as mentors put that much time into work that is worthy of being shared, which is why I asked all of you to commit to that. So I'll be following up. But I just think that's it. And so, I've had 2 students basically become nurse practitioners, good for them, and leave the organization without doing anything about publishing. And I had not said to them, I will publish your work, and I would have included them at that point. But they were moved on at that point and not interested in doing so. And so I think we as mentors have to think about those challenges up front with students.
I would say one of the things that mentors need to be thinking about is making sure that they're socializing the students that are working with them to the norms, because oftentimes the students are folks who are coming directly from the bedside, or they're in areas, now that are not their own. And it's important to share with them what the norms are, whether it's with that, the level of leadership that they have to interface with, or, whether it's appearance or whether it's, the way they present or something like that. I think that I learned that with a former student that, sometimes even just basically what's the proper business attire, when you're on an online, meeting, just because you're taking it from home doesn't mean you can wear a tank top, Like, you need to appreciate that you are a professional and you're representing a professional organization. And so including socialization in your mentoring, I think, is very important.
Yeah. I think, I've had both challenging and excellent experiences. I loved mentoring Kate. That was lovely. I think one of the hard things with the dissemination piece for quality and DNP projects goes back to the way the projects are approved. Because there is many journals would like either a letter from the IRB saying it's not human subjects research, but the IRBs are not interested in reviewing quality projects. And so it comes down to that dissemination piece, and then also what is free to be shared outside of the organization for a quality project versus quality data that belongs to the organization is protected. And so I think those pieces make the scholarly elements of the project can be kind of challenging. And I think also that aligning the timelines. Like, I have projects now where I'm like, this would make a great DNP project, but to bring a student in on it would be hard because we're already at the data collection spot. Someone identified it and we're like, okay, we're going to start collecting our pre-intervention data. If you were to bring a student in at that point, they have 4 months of scholarly work to do for theory, framework, and all of these other things before they would be ready to join that project. So getting that timeline aligned between where the organization is when they're ready to pull the trigger on a particular project and where the student is, I think it can be challenging to match those up. But when you can hit that, you get this like perfect alignment of that, all of the work and effort to move forward.
Any questions from the group?
I had a question about when you're mentoring a student, what are your favorite ways to kind of sync up with them? Like any project tracking tools that you have utilized that have been helpful that you can go log on and see progress reports and updates?
Megan was amazing at, we had for this project, a team site, and, you know, every team site has an adjoining SharePoint site kind of thing where you can park things, but part of the project management that Megan undertook, which I have now learned from, is to create folders on our team site where any, and, you know, to remind you about what happened in that project, we had to break it out into 3 smaller teams. And so there was a lot of, you know, that was the way we met the goals, is we needed 3 different teams working, you know, simultaneously. And there was no way to keep all of that together unless we had a shared file where all of the information could be. And we had a folder for presentations, and anybody who needed information, you know, maybe in one of the other groups could always just go in there and take what they needed, and, you know, just have a shared resource that worked really well, I think.
I will give a shout out for JBI PACES, which is the evidence-based practice project tracker, essentially. It is cloud-based, so everyone can log in and see it. Everyone who has a Lurie ID can log in, because Lurie is the clinical entity for Precise. And you can build in their audit tools and their reevaluation tools, and everything is all in there, and you can customize the questions you're asking. And then everyone can kind of see where the project is at. So use of those kinds of project trackers, and I know it's not the only one that's available, can be helpful, I think, especially if you have a bigger team. Yeah.
Did you use it on?
Not yet. Mhm.
How do you balance fostering student independence with providing sufficient guidance to ensure academic and clinical rigor in student projects?
I think I think an important thing, there's a couple of pieces to that question. So I have a couple of thoughts. One is about academic rigor. And so I just, you know, I'm involved in the student project now, and I think we were both, you know, just struggling a little bit with, there wasn't as much literature in an area that, but we both agreed it was an important area. And so then you just have to think about what your work, you know, think about look at the literature yourself as a mentor. And I, you know, as I was kind of looking around, realized, oh, you know, I'm on this International Standards Committee for Developmental Care, and guess what? There was a standard written that was evidence-based around the very area she was wanting to do her work in. And so, you know, I got all jazzed up one morning, and we had a little meeting, and that was like the best meeting we had, because we both just, all of a sudden, Chills was talking about, like, we just finally got excited about the project. We were both kind of struggling a little bit academically, where does this fit and where do we take it? But from that, we were able to really move it forward. I think keeping it clinically grounded, and, you know, having our leadership team has now said, you know, even a 5-minute presentation at the beginning of, like, what do you want to work on? They can share some ideas. You know, we don't have to take them all, but, you know, right, everybody can weigh in, kind of know what's going on. And then maybe another time, if it's a longer project, kind of update the leadership team so that they all know what we're doing. And then also we have a family partnership council, and I think family partners are really important in this work, and how are we engaging families? And so we laid that out as an expectation early on in meeting with the leadership team, that we hope that, you know, especially, but one of these projects is particularly families are the targets of this intervention. And so don't we want to ask family experts what they would think about whatever materials we're creating for, this is an educational intervention for families. So I think that's really a relevant thing. And I think including families in quality and evidence-based practice is really the wave of the future. And I think the next thing we have to figure out is how to pay families for their time. So.
I think one of the most interesting things about precepting and rewarding things is allowing students to be curious. And thankfully, I've been kind of blessed with having really curious and inquisitive folks. Pediatrics partnered with me. And so I love it when like I kind of have a couple ideas in my mind and like collaboration with my leadership team as far as projects go, but like having your students kind of acclimate to your unit, really experience it. I know most of them have like a day in the life experience with families and a patient. And then, so allowing for that appreciative inquiry and curiosity and balancing that with kind of the clinical needs of the unit. As Melanie alluded to earlier, we have recently started caring for a patient population that we never cared for before, patients with severe scoliosis that require halogravity traction for a prolonged period of time before it's safe for them to go to have a spinal fusion. And so we had implemented a project and there was definitely opportunity for improving that again. And so that was initially the goal of that project. However, you know, as all of you know, we have to be flexible and be able to pivot. And when we recognized that we were having lots of safety events related to EVD management, we really pivoted. So I apologize that she spent a lot of time and effort in the first part of her program working on that, but really helped the unit.
I'd say, I think in trying to foster independence while, you know, kind of keeping things on the rails, really relies on communication and expectations, and you have to trust people, you know. So Megan and I would meet and we'd say, okay, where are we now? You know, and it was like at least a weekly thing. And then, okay, you'll do this, I'll do that, you'll do this, you'll do, you know, and then, you know, off, you know, Megan knew full well what needed to be done, spent time doing it. I did other things. We would regroup. Okay, so where are we now? You know, and so always sort of checking in, making a plan, then being fine with, you know, how it goes. And then oftentimes I would learn a lot in that process, because Megan's like, okay, well, I did this, but then, you know, this happened. You know, well, we didn't really expect that. You know? And so then we would have to regroup. So I would say the key there to make sure you're always in sync, and as a leader, then making sure that your student is, you know, doing what's needed as well. It's just like any other oversight of any other staff. You know, you've got to give a lot of slack so people can learn, and even make some mistakes here and there, because that is really how you learn very deeply. But then, you know, to continue to be on the same page and moving forward. And so, you know, it's kind of a dance in a way.
Yeah, so one of the things for me is that I make it, and I'm sure Kate can speak to this, I make it really clear up front that if someone needs a lot of input from me as a mentor, I'm not the right mentor pair for them. They have to be very self-directed. I don't have the bandwidth to be able to really drive them forward, but I will follow them along and make sure that they're in a good spot. So that goes back to like the right mentor alignment. Like some people are much more like checking in more often. Like if you have a mentee that's like high needs mentee, I'm not the mentor for them. But if someone is very motivated, then I will be motivated right alongside them and provide them with the opportunities. And so I think that for me, it's about the right fit in terms of the mentor. It's the right fit for the project, but also the right temperament fit as well. I wanted to speak to what you were talking about with the working with the patients and families, because I find that to be a really interesting idea. It's something that's shifted in the research lens as well with the idea of co-production, but I haven't really heard people talk about co-production necessarily when it comes to evidence-based practice and quality, outside of them being sort of the subjects of those interventions. But I really like that idea of co-production with the quality lens. That's given me something to think about.
So thank you for that. Yeah.
And I think the hospital has a family partnership council. Different clinical areas may or may not have them. So there are resources you can go to begin to, in order to reinvent them. You can go to the hospital one as a guest and get some input, I would imagine.
Yeah. They were even talking about co-production at the last colloquium when it came to literature synthesis, to make sure that when you're doing a systematic review, that you're actually asking questions that the patients want answers to or the clinicians or whoever it is wants answers to when you're doing your literature synthesis. Because what's the point of doing a systematic review if then later people are like, well, that wasn't really a clinically relevant question to ask in your systematic review, or that's not an important thing to me as a patient. And so I think that's really interesting, and to think about it with quality as well, I think it is beneficial.
Sorry, go ahead.
This idea of work as imagined versus work as done is fascinating to me, because it's easy to sit in a room and look at a policy and say, I'd like, this is the policy. It doesn't seem like it's that hard to adhere by, but it's so important in doing quality improvement work to actually go to the people doing the work. They call it this Gemba walk, because they're the ones that are going to give you like the best ideas of how to improve this work. And so I do a lot of work with fall prevention. And I've been to the Family Advisory Board and the Kids Advisory Board several times and presenting the work that we're doing as an organization. But I've had some of the greatest input and feedback from particularly the Kids Advisory Board about like maybe expanding the sizes of socks that we have, the sizes of gowns or other things. So I think in going to the people who are doing the work and that the work's impacting is essential.
I just wanted to highlight one more thing that I learned as a mentor is that shaping the scope of a project so that it fits inside of an academic term or year is a fabulous thing for me to adopt, even when no students involved. And the reason for that is that projects can just go and go and go and go, and you're like, when can I be done with this? But if you define the scope the way you have to when you're working with a student, in this coming fiscal year, we need to accomplish this thing, but it has to be done by end of June, so we have a little bit of time for some data before we get to the end of the fiscal year, is like, to me, I'm like, duh, why didn't I think of this sooner, because it puts some guardrails around it, and you can say, oh, you know what, we'll attack that on the next phase, but that'll have to be the next fiscal year because that doesn't fit in this one. And it's something that I really drove home over these last 2 years of working with students, where starting with the end in mind and then working backwards for milestones and, goalposts to hit in what increments is, I am forever going to use that in my operations, even when there's no student. Yeah.
For 12:59, do you want?
Yeah. I think we can.
Any other questions?
Thank you guys so much for
Yeah.
coming.
Thank you.